Welcome everyone. You've got the D443 OA exam coming up, and you want to fully prepare for it. Well, we're going to help you with it. Our website has D443 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. In this video, we will cover questions from dermatological assessment, cardiovascular examination, respiratory findings, physical assessment, neuromusculoskeletal evaluation. So, let's get started.
1. A nurse assessing a patient with suspected liver dysfunction notices distinct yellow discoloration of the sclera during inspection. The nurse needs to confirm whether this finding represents true jaundice rather than another condition causing skin yellowing. Which additional clinical finding would best confirm a jaundice diagnosis? A. Yellowing limited to both palms. B. Dry flaky patches on the arms. C. Elevated bilirubin on lab results. D. Cool temperature in the extremities. Do you know the answer? Correct answer, C. Elevated bilirubin on lab results. Explanation: Option C is correct because jaundice results from excess bilirubin accumulating in the blood and tissues, so laboratory confirmation of elevated bilirubin directly supports the clinical finding of yellow scleral discoloration during assessment. Option A is incorrect because yellowing limited to the palms without scleral involvement is characteristic of carotenemia from excessive dietary carotene intake, not true jaundice caused by liver dysfunction or bilirubin elevation. Option B is incorrect because dry flaky skin patches typically indicate dehydration or a dermatological condition like eczema and are not a distinguishing clinical feature used to confirm a jaundice diagnosis. Option D is incorrect because cool temperatures in the extremities suggest poor peripheral circulation or cyanosis related to cardiovascular or respiratory compromise, which is not related to bilirubin accumulation that causes jaundice. Alright, let's tackle a question that gets to the heart of confirming jaundice during a health assessment. The scenario here is a nurse who spots yellow discoloration of the sclera, that's the white part of the eye, and needs to confirm whether this is true jaundice or something else entirely. So what is jaundice really? Jaundice happens when bilirubin, a yellow waste product from the normal breakdown of red blood cells, builds up in the blood and starts depositing in tissues. Normally the liver processes bilirubin and excretes it through bile. When the liver isn't working properly, or there's a blockage, bilirubin accumulates and turns the skin and sclera yellow. The key confirmation? Elevated bilirubin on lab results. That's the definitive clinical backup. Now, why not the other options? Yellowing limited to the palms, that's actually carotenemia, which comes from eating too many carotene-rich foods like carrots. The giveaway with carotenemia is that the sclera stay white. Dry flaky patches? That's a skin condition like eczema or dehydration. Nothing to do with bilirubin. Cool extremities point toward poor circulation or cardiovascular issues, again completely unrelated to bilirubin buildup. Here's a WGU D443 OA exam tip for you. When a question pairs scleral yellowing with a request for confirmation, think lab values, specifically bilirubin. The quick recall hook: yellow sclera plus elevated bilirubin equals jaundice, confirmed. Sclera tells you to look, labs tell you for sure. 2. A patient presents with yellow discoloration on the palms and soles during inspection, but both sclera remain completely white. The patient reports consuming large amounts of carrots and sweet potatoes daily for several months, without changes to other dietary habits. Which condition best matches these clinical findings? A. Carotenemia from excess dietary intake. B. Obstructive jaundice from bile duct blockage. C. Central cyanosis from poor oxygenation. D. Localized erythema from skin infection. What do you think is the answer? Correct answer, A. Carotenemia from excess dietary intake. Explanation. Option A is correct because carotenemia causes yellow discoloration on the palms, soles, and nasolabial folds from excess dietary carotene consumption, while the sclera remain completely white, clearly distinguishing this condition from true jaundice. Option B is incorrect because obstructive jaundice from bile duct blockage produces yellow discoloration of both the skin and sclera together, along with dark urine and clay-coloured stools, which does not match this patient presentation. Option C is incorrect because central cyanosis presents as bluish discoloration of skin and mucous membranes from inadequate oxygenation, which is entirely different from the yellow colouring found in this patient. Option D is incorrect because localised erythema from skin infection appears as redness and warmth at the infection site caused by increased blood flow and inflammatory response, not the yellow discoloration pattern described here. Now let's look at a condition that gets confused with jaundice all the time: carotenemia. Picture this: a patient comes in with yellow palms and soles, but the sclera are completely white. They've been eating loads of carrots and sweet potatoes daily for months. This is textbook carotenemia. Here's the science. Carotene is a yellow-orange pigment found in vegetables like carrots, sweet potatoes, and squash. When you eat a huge amount of them over weeks and months, excess carotene deposits in areas with thick skin: palms, soles, and the nasolabial folds around the nose. But it does not deposit in the sclera. That's the critical differentiator. Jaundice caused by bilirubin turns the sclera yellow. Carotenemia does not. So if a question describes yellow skin but white sclera plus a diet heavy in orange vegetables, that's carotenemia every time. Why not the other options? Obstructive jaundice would cause yellowing of both the skin and sclera together, plus dark urine and clay-coloured stools from bile duct blockage. Central cyanosis shows as bluish discoloration from poor oxygenation. Completely different colour, different mechanism. Localised erythema from infection shows redness and warmth, not yellow discoloration at all. Here's a WGU D443 OA exam tip for you. The sclera are your decision maker. White sclera with yellow skin equals carotenemia. Yellow sclera with yellow skin equals jaundice. Quick recall hook: white eyes, orange diet. Carotenemia, yellow eyes, liver problem, jaundice. 3. A home health nurse visits an elderly patient with dark skin and suspects poor oxygenation may be occurring. The nurse needs to check for cyanosis, but must select the most reliable assessment site given the patient heavy skin pigmentation. Which body location provides the most accurate cyanosis detection? A. Dorsal surface of both hands. B. Anterior surface of both forearms. C. Skin across the forehead area. D. Oral mucous membranes and nail beds. Do you know the answer? Correct answer: D. Oral mucous membranes and nail beds. Explanation: Option D is correct because in dark skin patients, cyanosis is most reliably detected at mucous membranes, nail beds, and conjunctiva, where melanin pigmentation does not obscure the bluish discoloration, indicating decreased oxygen saturation. Option A is incorrect because the dorsal hand surface in dark-skinned individuals contains significant melanin pigmentation that can easily conceal the subtle bluish colour changes associated with cyanosis, making this site unreliable for assessment. Option B is incorrect because the anterior forearm skin in dark-skinned patients has enough melanin pigment to reliably mask the subtle cyanotic colour changes, making this location much less accurate than mucous membranes for detection. Option C is incorrect because the forehead skin in dark-skinned patients carries sufficient melanin to obscure the subtle blue-grey colour changes, indicating cyanosis, making mucous membranes and nail beds far more reliable sites. This question is about assessing cyanosis in a patient with dark skin, and it tests something you absolutely need to know for clinical practice. Cyanosis is that bluish discoloration that shows up when oxygen saturation drops. In patients with lighter skin, you might catch it on the face or hands. But in patients with heavy skin pigmentation, melanin masks those subtle blue-grey colour changes on the skin surface. So where do you look? Oral mucous membranes and nail beds. These sites have minimal melanin interference, so the bluish tint from low oxygen actually shows through. The conjunctiva inside the lower eyelid is another reliable site for the same reason. Now, the wrong options. The dorsal surface of the hands has too much melanin in dark-skinned patients to reliably see cyanosis. Same goes for the anterior forearms and the forehead. All of these external skin surfaces carry enough pigment to hide the subtle colour shift. The answer always comes back to mucous membranes and nail beds, because melanin doesn't obscure those areas. Here's a WGU D443 OA exam tip for you. Whenever a question mentions dark skin and cyanosis assessment, jump straight to mucous membranes, nail beds, and conjunctiva. Quick recall hook. Dark skin go inside mouth, nails, eyelids. That's where the truth is. 4. A nurse caring for a newborn notices significant yellow skin discoloration across the trunk and face on the second day of life. The physician orders phototherapy for neonatal jaundice, and the nurse explains this treatment to the parents. Which statement best explains why phototherapy is used? A. It stimulates increased bile production. B. It converts bilirubin for body excretion. C. It promotes faster liver cell maturation. D. It raises infant body core temperature. What do you think is the answer? Correct answer, B. It converts bilirubin for body excretion. Explanation. Option B is correct because phototherapy uses specific light wavelengths to convert unconjugated bilirubin in the skin into water-soluble isomers that the newborn can then excrete more easily through both urine and stool. Option A is incorrect because phototherapy does not stimulate bile production in the liver. Its mechanism targets bilirubin molecules already deposited in the skin and converts their chemical structure for easier elimination. Option C is incorrect because phototherapy does not promote liver cell growth or accelerate hepatic maturation in the newborn. The treatment works externally on bilirubin deposited in the skin through a photochemical conversion process. Option D is incorrect because raising the infant core temperature is not a goal of phototherapy. In fact, overheating is a known complication that nurses must carefully monitor and prevent throughout each phototherapy treatment session. Let's break down why phototherapy works for neonatal jaundice. This is a concept that shows up in both pediatric and assessment contexts. When a newborn develops jaundice on day 2 of life, it's usually because their immature liver can't process bilirubin fast enough. Bilirubin builds up in the blood and deposits in the skin, giving that yellow colour. Phototherapy uses specific wavelengths of blue spectrum light that penetrate the skin and hit those bilirubin molecules directly. The light changes the chemical structure of unconjugated bilirubin, converting it into water-soluble isomers. Once water-soluble, the baby's body can excrete them through urine and stool without the liver needing to process them first. That's the mechanism. Light converts bilirubin for excretion. Why not the other answers? Phototherapy does not stimulate bile production. That's liver function, and the light works on bilirubin already in the skin, not the liver itself. It doesn't speed up liver maturation either. The newborn liver develops on its own timeline, and raising body temperature is actually a complication nurses need to watch for during phototherapy, not the goal. Here's a WGU D443 OA exam tip for you. When you see phototherapy and newborn jaundice, the answer is always about converting bilirubin for excretion. Quick recall hook. Photo means light, light converts bilirubin. Converted bilirubin gets excreted. Light in, bilirubin out. 5. A patient in the emergency department shows pallor across the conjunctiva and oral mucous membranes combined with fatigue, dizziness and mild tachycardia during the initial assessment. The nurse suspects anemia as the underlying cause and plans the next assessment step. Which action is most appropriate? A. Apply a wood lamp on exposed skin. B. Assess turgor on the forearm skin. C. Palpate temperature using dorsal hand. D. Inspect nail beds for fungal infection. Can you guess the answer? Correct answer, C. Palpate temperature using dorsal hand. Explanation. Option C is correct because palpating skin temperature with the dorsal hand evaluates peripheral circulation status, and when combined with the pallor findings and tachycardia, it supports further clinical assessment of this suspected anemia. Option A is incorrect because a wood lamp uses ultraviolet light to detect fluorescent skin conditions like certain fungal infections, which has absolutely no relevance to evaluating pallor or assessing a patient with suspected anemia. Option B is incorrect because skin turgor assessment primarily evaluates hydration status by testing the elasticity and recoil speed of the skin, not the tissue perfusion or hemoglobin levels that would be relevant to anemia. Option D is incorrect because inspecting nail beds specifically for fungal infection is a dermatological assessment that does not contribute to evaluating the pallor, tachycardia, or suspected anemia presented in this patient scenario. Here's a clinical reasoning question about what to do next when you suspect anemia. The patient has pallor in the conjunctiva and oral mucous membranes, fatigue, dizziness, and mild tachycardia. All of those point toward anemia. Reduced hemoglobin means less oxygen delivery, so the heart speeds up to compensate, and the patient feels lightheaded. Now the question asks for the most appropriate next assessment step. The answer is palpating temperature using the dorsal hand. Why? Because in a patient you suspect has anemia, checking peripheral circulation status adds to your clinical picture. The dorsal hand is used for temperature assessment because the skin there is thinner and more sensitive to temperature differences. Cool extremities combined with pallor and tachycardia strengthens the case that perfusion is compromised. The other options don't fit. A wood lamp uses ultraviolet light to detect fungal skin conditions, completely irrelevant to anemia. Skin turgor assessment checks hydration, not hemoglobin or perfusion. Inspecting nail beds for fungal infection is a dermatological concern that has nothing to do with the anemia workup. Here's a WGU D443 OA exam tip for you. When a question gives you pallor plus tachycardia plus fatigue and asks for the next assessment, think circulation. Palpate for temperature. Quick recall hook. Pallor plus tachycardia. Check perfusion with the dorsal hand. 6. A patient visits the clinic concerned about a mole that has recently changed over the past 3 months. The nurse applies the standard ABCD screening rule to evaluate the mole for possible malignancy during the skin examination. Which specific component of this screening rule addresses changes happening over time? A. Evolution or recent change in mole. B. Colour variation within the lesion. C. Irregular borders around the edges. D. Asymmetry of the overall lesion shape. Do you know the answer? Correct answer, A. Evolution or recent change in mole. Explanation. Option A is correct because the letter E in the ABCDE screening rule specifically stands for evolution, referring to any recent changes in the size, shape, colour, or symptoms of a mole occurring over time. Option B is incorrect because colour variation describes multiple colours within the mole, such as brown, black or red observed at a single assessment point, not changes that have occurred progressively over time. Option C is incorrect because irregular borders describe ragged, notched or blurred edges of the mole found during one examination, and this criterion does not address how the mole has changed over time. Option D is incorrect because asymmetry refers to one half of the mole not matching the other half, which is a structural finding observed at one point in time rather than a measure of change. This one tests whether you know the ABCDE rule for melanoma screening, specifically the letter E. The ABCD rule is a systematic way to evaluate moles for possible skin cancer. Each letter stands for something different. A is asymmetry. One half of the mole doesn't mirror the other. B is border. The edges are irregular, ragged or blurred. C is colour. There are multiple colours within the lesion like brown, black, red or blue. D is diameter. The mole is larger than 6 millimeters, roughly the size of a pencil eraser. And E is evolution. This is the one that addresses changes over time. Evolution means any recent change in the mole's size, shape, colour, elevation, or symptoms like itching or bleeding. The question specifically asks which component addresses changes happening over time, and that's evolution. Colour variation is observed at a single point, not over time. Irregular borders are a one-time structural finding. Asymmetry is also a single moment observation. Only evolution captures the time dimension. Here's a WGU D443 OA exam tip for you. If a question asks about change over time in the ABCDE rule, the answer is always E for evolution. Quick recall hook. E equals evolution equals change over time. The E is the time traveller of the ABCD rule. 7. A nurse is teaching a fair-skinned patient with a family history of melanoma about performing monthly skin self-examinations at home using a mirror for hard-to-see body areas. The patient asks the nurse to explain why regular self-checks matter. Which response best states the primary reason? A. To track healing of skin abrasions. B. To assess overall skin moisture levels. C. To monitor skin texture and dryness. D. To find new or changing growths early. Do you know the answer? Correct answer. D. To find new or changing growths early. Explanation. Option D is correct because the primary purpose of monthly skin self-examination is early detection of new or changing moles, growths, or lesions that could indicate skin cancer, allowing for prompt professional evaluation. Option A is incorrect because tracking healing of minor skin abrasions is a basic wound care concern and is not the primary cancer detection purpose that drives the widely recommended practice of monthly skin self-examinations. Option B is incorrect because assessing overall skin moisture levels relates to general dermatological health and comfort rather than the skin cancer screening and early detection focus that is the main goal of monthly self-examination. Option C is incorrect because monitoring skin texture and dryness is a routine skincare activity rather than the early identification of potentially cancerous skin changes, which is the primary clinical purpose of monthly self-examinations. Straightforward but important. Why do we tell patients to do monthly skin self-exams? The answer is early detection. The whole point of regular self-examination is catching new or changing growths before they become a serious problem. Skin cancer, particularly melanoma, has a dramatically better prognosis when caught early. A fair-skinned patient with a family history of melanoma is at higher risk, which makes self-screening even more critical. You're looking for new moles, existing moles that change in size or shape or colour, or any lesion that looks different from the rest. The other options miss the mark completely. Tracking healing of skin abrasions is basic wound care, not cancer screening. Assessing skin moisture relates to general dermatological comfort. Monitoring texture and dryness is routine skincare. None of those are why clinical guidelines specifically recommend monthly self-exams. The reason is cancer detection, finding suspicious changes early so you can get to a dermatologist before things progress. Here's a WGU D443 OA exam tip for you. When a question asks about the purpose of monthly skin self-exam, the answer is always early detection of new or changing lesions. Quick recall hook. Self-exam equals self-surveillance. You're the first line of defense. Find it early, treat it early. 8. A nurse documents a flat, discoloured spot on a patient, measuring less than 1 centimetre that cannot be felt during palpation. The spot has no elevation above the surrounding skin surface and contains no fluid. Which primary skin lesion classification best describes this clinical finding? A. Papule because it is raised and firm. B. Macule because it is flat and small. C. Vesicle because it holds clear fluid. D. Nodule because it extends into dermis. What do you think is the answer? Correct answer. B. Macule because it is flat and small. Explanation. Option B is correct because a macule is defined as a flat, non-palpable skin lesion, smaller than 1 centimetre, that differs in colour from surrounding skin, exactly matching all the assessment findings described here. Option A is incorrect because a papule is a solid, elevated lesion palpated above the skin surface during examination, which directly contradicts the description of a flat spot that cannot be detected by touch. Option C is incorrect because a vesicle is a small, elevated, fluid-filled blister on the skin surface containing clear, serous fluid, which does not match the flat, non-elevated lesion with no fluid content described here. Option D is incorrect because a nodule is a solid, palpable lesion larger than 1 centimetre extending deeper into the dermis, which directly contradicts the description of a small, flat, non-elevated spot on the surface. This question tests your knowledge of primary skin lesion classification, and the answer comes down to knowing your definitions precisely. The scenario describes a flat, discoloured spot under 1 centimetre that you can't feel with palpation. No elevation, no fluid. That's a macule. A macule is a flat, non-palpable spot smaller than 1 centimetre that differs in colour from the surrounding skin. A freckle is a classic example. Now, the trick on these questions is knowing what makes each lesion type different. A papule is solid and raised. You can feel it above the skin surface, like a small firm bump. That contradicts flat and non-palpable. A vesicle is a small blister filled with clear fluid. Again, elevated and fluid-filled, neither of which applies here. A nodule extends deeper into the dermis, is larger than 1 centimetre, and is definitely palpable. All three of those are disqualified by the description of flat, small, and not palpable. Here's a WGU D443 OA exam tip for you. When a question describes a skin lesion, key into 3 characteristics. Is it flat or raised, solid or fluid-filled, and what size? Flat plus small plus non-palpable always equals macule. Quick recall hook. Macule sounds like molecule, tiny and flat, you can't feel it. 9. A bedbound hospitalised patient develops a reddened area over the sacrum. The nurse presses on the area with a gloved finger and observes that the redness does not fade or blanch under pressure. The surrounding skin remains completely intact with no break or opening. Which pressure ulcer stage matches this? A. Stage 2 partial thickness skin loss. B. Stage 4 with exposed bone visible. C. Stage 1 non-blanchable redness present. D. Stage 3 full thickness tissue loss. What do you think is the answer? Correct answer, C. Stage 1 non-blanchable redness present. Explanation. Option C is correct because a stage 1 pressure ulcer is specifically defined by intact skin with non-blanchable redness, meaning the reddened area does not turn white when pressed, which exactly matches this patient scenario. Option A is incorrect because a stage 2 pressure ulcer involves partial thickness skin loss presenting as a shallow open wound or fluid-filled blister, but this patient has completely intact skin with no open areas present. Option B is incorrect because a stage 4 pressure ulcer involves full thickness tissue loss with exposed bone, tendon, or muscle visible in the wound bed, which is dramatically more severe than the intact reddened skin. Option D is incorrect because a stage 3 pressure ulcer involves full thickness tissue loss, where subcutaneous fat may become visible through the wound bed, which is significantly more severe than intact skin with redness. Pressure ulcer staging is one of those topics where the definitions are very specific, and they test you on those specifics. Here's the scenario. A bedbound patient has a reddened area over the sacrum. The nurse presses on it, and the redness does not blanch. It doesn't turn white under pressure. The skin is still intact. No breaks, no openings. That's a stage 1 pressure ulcer. Stage 1 is defined by two things: intact skin and non-blanchable redness. Blanchable redness is actually normal. You press, it turns white briefly, then returns to colour. Non-blanchable redness means the tissue underneath has been damaged enough that the redness persists under pressure. That's the early warning sign. Stage 2 involves partial thickness skin loss. You'd see a shallow open wound or a fluid-filled blister. The skin is broken. Stage 3 goes deeper. Full thickness tissue loss where you might see subcutaneous fat. Stage 4 is the worst. Exposed bone, tendon or muscle. The patient in this question has intact skin and non-blanchable redness and nothing else. That's stage 1, full stop. Here's a WGU D443 OA exam tip for you. Intact skin plus non-blanchable redness equals stage 1. The moment the skin breaks, you're at stage 2 or beyond. Quick recall hook, stage 1. Skin is still one piece, intact but red and won't blanch. 10. During a health promotion clinic visit, a nurse recommends that a patient with multiple moles and a strong family history of skin cancer start performing regular skin self-examinations at home. The nurse explains the proper frequency recommended by clinical guidelines. How often should this patient perform skin self-examination? A. Once each month on a regular schedule. B. Every week immediately after showering. C. Only at annual physical examination visits. D. Every 6 months at the bare minimum. What do you think is the answer? Correct answer, A. Once each month on a regular schedule. Explanation: option A is correct, because clinical health promotion guidelines recommend performing a thorough skin self-examination once each month, using a mirror for hard-to-see body areas to detect any new or changing lesions. Option B is incorrect because performing skin examinations every week after showering is more frequent than standard clinical guidelines recommend, and this excessive frequency is not necessary for effective skin cancer screening efforts. Option C is incorrect because waiting for annual physical examination visits means relying solely on the healthcare provider and missing the opportunity for monthly self-detection of important skin changes between appointments. Option D is incorrect because examining skin only every 6 months creates a significant time gap that may allow important changes in existing moles or new suspicious lesions to go unnoticed for far too long. Quick one. How often should a patient with multiple moles and a family history of skin cancer perform skin self-examinations? The answer is once each month on a regular schedule. Clinical guidelines consistently recommend monthly self-exams for early detection of skin changes. This applies to everyone, but especially to high-risk patients with multiple moles and family history of skin cancer. Why not weekly? Weekly exams after showering sounds thorough, but it's more frequent than guidelines recommend and isn't necessary for effective screening. You want a consistent schedule that's sustainable, not excessive. Why not annually? Relying only on annual physicals with a provider means you could miss something for up to 12 months. Self-examination fills the gap between professional visits. Why not every 6 months? That creates a 6-month window where a rapidly changing mole could go unnoticed. Monthly hits the right balance. Frequent enough to catch changes early, practical enough to maintain as a habit. Here's a WGU D443 OA exam tip for you. Skin self-exam frequency equals monthly. If you see the word monthly with self-exam, that's your answer. Quick recall hook. Monthly mole monitoring, 3 M's. Once a month, every month. 11. A nurse performing a cardiovascular assessment auscultates over the carotid artery using the bell of the stethoscope and hears a whooshing sound indicating turbulent blood flow within the vessel. This finding commonly results from narrowing or stenosis of the artery. Which term correctly identifies this auscultatory finding? A, a pericardial friction rub sound. B, a ventricular gallop heart rhythm. C, a murmur from heart valve disease. D, a bruit from arterial flow turbulence. Can you guess the answer? Correct answer, D, a bruit from arterial flow turbulence. Explanation. Option D is correct because a bruit is a whooshing or blowing sound heard over arteries during auscultation that indicates turbulent blood flow, most commonly caused by stenosis or atherosclerotic narrowing within the vessel. Option A is incorrect because a pericardial friction rub is a scratchy, high-pitched sound best heard at the left sternal border and associated with pericarditis, not a whooshing sound heard over a peripheral carotid artery. Option B is incorrect because a ventricular gallop is an extra heart sound detected during cardiac auscultation over the heart apex, not a whooshing sound heard over a peripheral artery like the carotid. Option C is incorrect because a heart murmur results from turbulent flow across cardiac valves and is auscultated over specific valve areas on the chest, whereas a bruit specifically describes turbulence occurring in peripheral arteries. This question is about a specific finding during cardiovascular assessment, a whooshing sound heard over the carotid artery. That sound has a name, bruit. A bruit is a whooshing or blowing sound you hear when you auscultate over an artery, and it tells you there's turbulent blood flow inside that vessel. The most common cause is atherosclerotic narrowing or stenosis. Blood flowing through a narrowed artery creates turbulence, and that turbulence produces the whooshing sound you pick up with the bell of the stethoscope. Now the distractors. A pericardial friction rub is a scratchy sound you hear at the left sternal border, and it's associated with pericarditis, inflammation of the sac around the heart. Completely different location and sound quality. A ventricular gallop is an extra heart sound, an S3 or S4, heard at the heart apex during cardiac auscultation. It's not a whooshing sound over a peripheral artery. A heart murmur comes from turbulent flow across heart valves, heard over specific valve areas on the chest, not over the carotid in the neck. The key distinction: bruits happen in arteries, murmurs happen at valves. Here's a WGU D443 OA exam tip for you. Whooshing sound over an artery means bruit. If it's over the heart, think murmur. Location tells you the answer. Quick recall hook: bruit sounds like brewy. Think of blood brewing turbulence inside a narrowed artery. 12. A patient presents with bilateral ankle swelling, distended jugular veins visible above the clavicle, and an enlarged liver discovered during abdominal palpation. The nurse recognises that these findings together are classic indicators of a specific type of cardiac dysfunction. Which condition best matches these signs? A. Right-sided heart failure with systemic congestion. B. Left-sided heart failure with lung congestion. C. Cardiac tamponade from pericardial fluid. D. Aortic stenosis causing valve narrowing. Do you know the answer? Correct answer: A. Right-sided heart failure with systemic congestion. Explanation. Option A is correct because right-sided heart failure produces systemic venous congestion, leading to peripheral ankle edema, jugular vein distension, and hepatomegaly as blood backs up through the venous return system. Option B is incorrect because left-sided heart failure primarily affects the pulmonary circuit, producing respiratory symptoms such as lung crackles, dyspnea, and orthopnea, rather than the peripheral edema and jugular vein distension described. Option C is incorrect because cardiac tamponade results from fluid accumulating in the pericardial sac and compressing the heart, which presents with hypertension and muffled heart sounds, not hepatomegaly and bilateral ankle swelling. Option D is incorrect because aortic stenosis involves narrowing of the aortic valve that may produce a systolic murmur and possible syncope, but does not directly cause the jugular distension and hepatomegaly pattern described. This question gives you a classic triad: bilateral ankle swelling, distended jugular veins, and an enlarged liver. Your job is to recognize what ties all three together. The answer is right-sided heart failure with systemic congestion. Here's the logic. The right side of the heart receives blood returning from the body through the venous system and pumps it to the lungs. When the right side fails, it can't move that blood forward efficiently. Blood backs up into the systemic venous system. That backup causes jugular vein distension because blood can't drain from the head and neck. It causes hepatomegaly because the liver becomes engorged with backed up venous blood. And it causes peripheral edema, ankle swelling, because fluid leaks into the tissues from the congested venous system. Left-sided heart failure is different. It affects the pulmonary circuit, so you'd see lung crackles, shortness of breath, and orthopnea. Not the peripheral signs described here. Cardiac tamponade is fluid compressing the heart from outside, causing hypertension and muffled heart sounds. Aortic stenosis narrows the aortic valve and might cause a murmur or syncope, but doesn't produce this systemic congestion pattern. Here's a WGU D443 OA exam tip for you. The triad of JVD plus hepatomegaly plus peripheral edema equals right-sided heart failure. Think, blood backs up into the body. Quick recall hook. Right side fails, blood goes right back into the body. Neck, liver, ankles. 13. A post-operative patient reports pain in one calf, and the nurse observes unilateral redness, warmth and swelling in that lower leg during the assessment. The nurse suspects a blood clot has formed within a deep vein. Which diagnostic test would most reliably confirm this suspected venous thrombosis? A. Ankle brachial index measurement test. B. Doppler ultrasound of the affected leg. C. Capillary refill time assessment check. D. Posterior tibial pulse palpation test. Do you know the answer? Correct answer: B. Doppler ultrasound of the affected leg. Explanation: Option B is correct because a Doppler ultrasound is the standard and most reliable diagnostic test used to directly visualize blood flow patterns within the veins and detect the presence of a deep venous thrombus. Option A is incorrect because the ankle brachial index compares blood pressure measurements in the ankle and arm to screen for peripheral arterial disease and is not designed to detect blood clots within the deep veins. Option C is incorrect because capillary refill time evaluates peripheral arterial perfusion and blood flow to the distal tissues broadly and cannot confirm or reliably detect the specific presence of a deep venous blood clot. Option D is incorrect because palpating the posterior tibial pulse assesses the arterial blood supply reaching the lower extremity and is not an appropriate diagnostic method for confirming a suspected venous thrombus in deep veins. Post-operative patient with unilateral calf pain, redness, warmth and swelling. The nurse suspects a deep vein thrombosis. The question asks which test confirms it. The answer is Doppler ultrasound. A Doppler ultrasound is the gold standard diagnostic tool for DVT. It directly visualizes blood flow patterns inside the veins and can show exactly where a clot is blocking or altering flow. It's non-invasive, widely available and highly accurate. The wrong answers all assess different things. The ankle brachial index compares blood pressure at the ankle and arm to screen for peripheral arterial disease. It's about arteries, not veins. Capillary refill time gives a general sense of peripheral perfusion, but can't pinpoint a clot in a deep vein. Palpating the posterior tibial pulse checks arterial supply to the foot. Again, arterial assessment, not venous. When a question describes suspected DVT and asks for the diagnostic test, it's always Doppler ultrasound. Here's a WGU D443 OA exam tip for you. DVT confirmation equals Doppler ultrasound. Arteries get pressure tests and pulse checks, veins get ultrasound. Quick recall hook. DVT and Doppler both start with DD for deep, D for Doppler. 14. A nurse documents a newly detected heart murmur during a patient assessment. the murmur is soft but easily heard with the stethoscope on the chest wall, and no palpable thrill is detected during the examination. Which murmur grade best matches this finding? A. Grade 1. Barely audible on auscultation. B. Grade 4 loud with a palpable thrill. C. Grade 2 soft but easily heard clearly. D. Grade 6 heard without stethoscope contact. What do you think is the answer? Correct answer, C. Grade 2 soft but easily heard clearly. Explanation? Option C is correct, because a grade 2 murmur is defined as soft but easily heard with the stethoscope on the chest, with no accompanying thrill, which matches all clinical findings described in the scenario. Option A is incorrect because a grade 1 murmur is barely audible and extremely difficult to detect even with careful focused auscultation, which does not match the description of a murmur that is easily heard. Option B is incorrect because a grade 4 murmur is loud and accompanied by a palpable thrill on the chest wall, but the scenario specifically states no thrill was detected during this patient assessment. Option D is incorrect because a grade 6 murmur is so loud it can be heard with the stethoscope off the chest surface, which represents a far more severe finding than the soft murmur described. Heart murmur grading shows up on exams because the definitions are very precise. This scenario describes a murmur that is soft but easily heard with the stethoscope on the chest, with no palpable thrill. That's a grade 2 murmur. The grading scale runs from 1 to 6. Grade 1 is barely audible. You really have to strain to hear it, even with focused auscultation. Grade 2 is soft but clearly audible when the stethoscope is on the chest, no thrill. Grade 3 is moderately loud, still no thrill. Grade 4 is loud with a palpable thrill, meaning you can feel the vibration on the chest wall with your hand. Grade 5 is very loud with a thrill, and you can hear it with just the edge of the stethoscope touching. Grade 6 is so loud you can hear it, with the stethoscope lifted completely off the chest. The question describes soft but easily heard, no thrill. That knocks out grade 1 because it's easily heard, not barely audible. It knocks out grade 4 because there's no thrill. And grade 6 is way beyond what's described. That leaves grade 2. Here's a WGU D443 OA exam tip for you. The thrill is the dividing line. Grades 1 through 3 have no thrill. Grade 4 and above have a thrill. If the question says no thrill and easily heard, it's grade 2. Quick recall hook. 2 is soft but true. You can truly hear it without straining. 15. A patient with known atherosclerosis reports cramping leg pain that occurs during walking and resolves completely after a few minutes of rest. The nurse finds cool pale feet with diminished pedal pulses during lower extremity assessment. Which condition best explains this combination of clinical findings? A. Deep vein thrombosis with venous clot. B. Varicose veins from valve dysfunction. C. Chronic venous insufficiency with edema. D. Peripheral arterial disease with claudication. Can you guess the answer? Correct answer, D. Peripheral arterial disease with claudication. Explanation. Option D is correct because peripheral arterial disease causes intermittent claudication, defined as leg pain with walking that resolves upon rest, combined with cool pale extremities and diminished pulses from atherosclerotic arterial narrowing. Option A is incorrect because deep vein thrombosis typically presents with unilateral swelling, warmth and redness in the affected leg, rather than the cool pale extremities and exercise-related cramping pain pattern described in this scenario. Option B is incorrect because varicose veins result from venous valve dysfunction, causing visible bulging dilated veins and leg heaviness, not the cool pale feet with weak pulses and exercise-induced cramping pain described here. Option C is incorrect because chronic venous insufficiency typically causes dependent edema, brownish skin discoloration, and leg heaviness rather than the cool pale extremities and diminished pedal pulses associated with arterial disease. This question presents a classic pattern you need to recognize immediately. Cramping leg pain with walking that goes away with rest, cool pale feet, diminished pedal pulses, and a history of atherosclerosis. That's peripheral arterial disease with intermittent claudication. Intermittent claudication is the hallmark symptom of PAD. The muscles in the legs need more blood during exercise, but the atherosclerotic narrowing in the arteries can't deliver enough, so you get cramping pain with walking. Stop walking, demand drops, pain resolves. The cool, pale feet and weak pulses confirm that arterial blood supply to the extremities is reduced. Now the distractors. DVT presents with unilateral swelling, warmth and redness, the opposite of cool and pale. Varicose veins cause visible bulging veins and leg heaviness from valve dysfunction, not the exercise-related cramping and weak pulses pattern. Chronic venous insufficiency causes edema and brownish skin discoloration from venous stasis, again different from cool pale extremities with diminished pulses. The key distinction: arterial problems give you cool, pale, pulseless. Venous problems give you warm, swollen, discoloured. Here's a WGU D443 OA exam tip for you. Pain with walking plus rest relief plus diminished pulses equals PAD with claudication. The keyword claudication literally means limping. Quick recall hook: claudication equals sign cramping that clamps down when you walk. 16. A nurse auscultates the lungs of a patient admitted with pneumonia and hears discontinuous popping sounds during the inspiratory phase in the lower lung fields. These sounds persist and are not cleared when the patient coughs. Which type of adventitious breath sound does this finding best represent? A. Crackles heard during the inspiration phase. B. Raunchy from mucus in the large airways. C. Stridor indicating upper airway obstruction. D. Wheezing from narrowed bronchial passages. Do you know the answer? Correct answer: A. Crackles heard during the inspiration phase. Explanation: Option A is correct because crackles are discontinuous popping or bubbling sounds heard primarily during inspiration, commonly associated with pneumonia, pulmonary edema, or heart failure affecting the alveoli in the lower lung fields. Option B is incorrect because raunchy are low-pitched, continuous rumbling sounds caused by secretions in the large airways typically associated with bronchitis or chronic obstructive pulmonary disease rather than the discontinuous popping sounds described. Option C is incorrect because stridor is a high-pitched, harsh sound heard during inspiration that is caused by upper airway obstruction, not the discontinuous popping sounds heard in the lower lung fields during this assessment. Option D is incorrect because wheezing produces a high-pitched, continuous musical sound from narrowed bronchial passages, most commonly heard during expiration, which differs significantly from the discontinuous inspiratory popping sounds described. Lung sounds. You need to know each type cold. This question describes discontinuous popping sounds during inspiration in the lower lung fields of a pneumonia patient. Those sounds persist after coughing. That's crackles. Crackles are caused by fluid or exudate in the alveoli. During inspiration, as air enters and pops open fluid-filled alveoli, you get those characteristic discontinuous popping or bubbling sounds. They're commonly associated with pneumonia, pulmonary edema, and heart failure. The fact that they don't clear with coughing helps differentiate them from sounds caused by movable secretions. Raunchy are different. Low-pitched, continuous rumbling sounds from secretions in the large airways, and they often clear or change when the patient coughs. Stridor is a high-pitched, harsh sound from upper airway obstruction, typically heard during inspiration, but it's a single continuous sound, not discontinuous pops. Wheezing is a high-pitched, continuous musical sound from narrowed bronchial passages, usually heard on expiration. The key word in this question is discontinuous. Crackles are the only discontinuous adventitious breath sound. Everything else, raunchy, stridor, wheezing, is continuous. Here's a WGU D443 OA exam tip for you. Discontinuous popping on inspiration equals crackles. Continuous sounds are everything else. Quick recall hook. Crackles crack and pop like cereal in milk. Short, separate bursts, not a smooth, continuous sound. 17. A nurse assessing a patient with long-standing chronic obstructive pulmonary disease observes an increased front-to-back chest diameter and the patient breathing through pursed lips during each exhalation to maintain airway pressure and slow expiratory flow. Which clinical finding best describes this chest shape change? A. Pectus excavatum with sunken sternum. B. Scoliosis with lateral spine curvature. C. Barrel chest from chronic air trapping. D. Flail chest from multiple rib fractures. Can you guess the answer? Correct answer, C. Barrel chest from chronic air trapping. Explanation. Option C is correct because barrel chest describes an increased anterior-posterior diameter resulting from chronic hyperinflation and air trapping in the lungs, which is a hallmark physical finding seen in long-standing COPD patients. Option A is incorrect because pectus excavatum is a congenital condition where the sternum is depressed inward, creating a concave chest wall, which is entirely unrelated to chronic obstructive pulmonary disease or air trapping. Option B is incorrect because scoliosis involves abnormal lateral curvature of the spine that may alter chest shape, but is a musculoskeletal condition, not a result of chronic air trapping from obstructive lung disease. Option D is incorrect because flail chest occurs when multiple adjacent ribs sustain fractures in two or more places, creating a paradoxically moving chest segment, which is a traumatic injury unrelated to chronic lung disease. A COPD patient with an increased front-to-back chest diameter and pursed lip breathing. What's the chest shape called? Barrel chest. Barrel chest develops over time in patients with chronic obstructive pulmonary disease because of chronic air trapping. The lungs stay hyperinflated. They can't fully exhale, so residual air accumulates. Over years, this persistent hyperinflation pushes the ribs outward, increasing the anterior-posterior diameter until it nearly equals the lateral diameter. The chest starts to look like a barrel, round in cross-section. Pursed lip breathing is a compensatory technique COPD patients use to slow down exhalation and keep their airways open longer. The other options represent completely different conditions. Pectus excavatum is a congenital defect where the sternum caves inward, a sunken chest, not an expanded one. Scoliosis is lateral curvature of the spine, which can change chest shape but has nothing to do with air trapping. Flail chest happens when multiple adjacent ribs break in two or more places, creating a segment that moves paradoxically during breathing. That's a traumatic injury, not a chronic change. Here's a WGU D443 OA exam tip for you. COPD plus increased AP diameter equals barrel chest. If the question mentions air trapping or hyperinflation, barrel chest is your answer. Quick recall hook. COPD traps air inflates the chest looks like a barrel, trapped air =, barrel shape. 18. A nurse examines the fingers of a patient with a chronic respiratory condition and notices the angle at the nail base has widened beyond normal limits. When the patient places both index fingernails together back to back, no diamond-shaped gap appears between them. Which clinical finding does this represent? A. Koilonychia indicating iron deficiency. B. Paronychia from a nail bed infection. C. Bowlines from interrupted nail growth. D. Clubbing associated with chronic hypoxia. What do you think is the answer? Correct answer, D. Clubbing associated with chronic hypoxia. Explanation. Option D is correct because digital clubbing involves loss of the normal nail bed angle and a positive Shamroth sign where no diamond-shaped gap appears between opposing fingernails, commonly found in chronic hypoxic respiratory conditions. Option A is incorrect because koilonychia refers to spoon-shaped nails that curve inward and upward at the edges, associated with iron deficiency anemia, which is a completely different nail abnormality from clubbing. Option B is incorrect because paronychia is an infection of soft tissue surrounding the nail, causing localized redness, swelling, and pain, which does not involve nail angle changes or the absent diamond gap in clubbing. Option C is incorrect because bowlines are horizontal depressions across the nail plate from temporary interruption of nail growth during systemic illness, which is entirely unrelated to nail angle changes in clubbing. This question is about a nail finding in a patient with chronic respiratory disease. The nail base angle has widened beyond normal, and when the patient places both index fingernails together back to back, there's no diamond-shaped gap between them. That's clubbing with a positive Shamroth sign. In healthy nails, when you press two fingernails together base to base, you see a small diamond-shaped window of light between them. With clubbing, the nail bed angle widens so much, exceeding 160 degrees, that this gap disappears completely. Clubbing is associated with chronic hypoxia from conditions like COPD, lung cancer, cystic fibrosis, and congenital heart defects. The body's response to prolonged low oxygen levels causes soft tissue growth at the nail base. The other options are distinct nail abnormalities. Koilonychia means spoon-shaped nails that curve upward, associated with iron deficiency anemia. Paronychia is an infection around the nail causing redness, swelling, and pain. Nothing to do with the nail angle. Bowlines are horizontal grooves across the nail from temporarily interrupted nail growth during a systemic illness. None of these involve the nail angle or the absent diamond gap. Here's a WGU D443 OA exam tip for you. Widened nail angle plus absent diamond gap plus chronic respiratory disease equals clubbing. Quick recall hook: clubbing closes the diamond. No diamond, no good. Think chronic hypoxia. 19. A nurse assessing a patient in the emergency department observes rapid breathing with visible inward pulling of the skin between the ribs during each inspiratory effort. The patient also demonstrates nasal flaring with every breath taken. Which clinical term best describes the skin pulling seen between the ribs? A. Paradoxical chest wall movement pattern. B. Intercostal retractions during inspiration. C. Subcutaneous emphysema beneath the skin. D. Accessory muscle use during exhalation. What do you think is the answer? Correct answer: B. Intercostal retractions during inspiration. Explanation: Option B is correct because intercostal retractions refer to visible inward pulling of the skin and soft tissue between the ribs during inspiration, which is a classic and widely recognized sign of significant respiratory distress. Option A is incorrect because paradoxical chest wall movement describes a chest segment moving inward during inspiration and outward during expiration, typically seen with flail chest from traumatic multiple rib fractures. Option C is incorrect because subcutaneous emphysema is air trapped beneath the skin, producing a crackling sensation when palpated, which is entirely different from visible inward skin retraction between the ribs. Option D is incorrect because accessory muscle use involves recruitment of additional neck and shoulder muscles to assist breathing, which does not specifically describe the visible inward skin pulling between the ribs. The question describes visible inward pulling of the skin between the ribs during inspiration, paired with nasal flaring. The term for that skin pulling between the ribs is intercostal retractions. Intercostal means between the ribs. When a patient is in significant respiratory distress, they're generating very strong negative pressure in the chest to pull air in. That negative pressure is so intense that it sucks the soft tissue between the ribs inward during each breath. You can visually see the skin dipping in between the rib spaces. Combined with nasal flaring, this paints a picture of a patient working hard just to breathe. The distractors represent other findings. Paradoxical movement is when a chest segment moves inward during inspiration and outward during expiration. That's flail chest from traumatic rib fractures, a different mechanism entirely. Subcutaneous emphysema is air trapped under the skin that crackles when you palpate it. You feel it, not see inward pulling. Accessory muscle use means the neck and shoulder muscles are recruiting to help with breathing, which is another sign of distress but doesn't describe the specific rib space retraction. Here's a WGU D443 OA exam tip for you. Skin pulling inward between the ribs during inspiration equals intercostal retractions. The word intercostal is your clue. Inter means between, costal means ribs. Quick recall hook. Intercostal retractions equal sine skin pulls in between the ribs. Intercostal, inward. 20. A patient who recently underwent abdominal surgery has diminished breath sounds and dull percussion notes over the right lower lung field during the post-operative assessment. The nurse suspects partial collapse of lung tissue in that area from shallow breathing after surgery. Which intervention is most appropriate? A. Encourage incentive spirometry device use. B. Administer broad-spectrum antibiotic therapy. C. Start nebulized bronchodilator treatment now. D. Apply continuous positive airway pressure. Can you guess the answer? Correct answer. A. Encourage incentive spirometry device use. Explanation. Option A is correct because incentive spirometry encourages sustained deep breathing and maximal lung inflation, which helps re-expand collapsed alveoli in post-operative atelectasis and is the standard first-line intervention for this condition. Option B is incorrect because broad-spectrum antibiotics treat bacterial infections and are not the appropriate intervention for atelectasis, which is a mechanical problem of collapsed lung tissue requiring deep breathing exercises. Option C is incorrect because nebulized bronchodilators are used to dilate narrowed airways in conditions like asthma or chronic obstructive pulmonary disease, not to re-expand collapsed alveoli caused by shallow post-operative breathing habits. Option D is incorrect because continuous positive airway pressure is typically reserved for more severe respiratory failure or obstructive sleep apnea, while incentive spirometry is the established standard first-line approach for routine post-operative atelectasis. Last one in this set, a post-operative patient with diminished breath sounds and dull percussion over the right lower lung. The nurse suspects atelectasis, which is partial collapse of lung tissue from shallow breathing after surgery. What's the most appropriate intervention? Incentive spirometry. An incentive spirometer is a handheld device that encourages the patient to take sustained deep breaths. Each deep breath helps re-expand collapsed alveoli by generating enough inspiratory pressure to pop them back open. It's the standard first-line intervention for post-operative atelectasis, and it's used millions of times a day in hospitals around the world. Why not the other options? Broad-spectrum antibiotics treat bacterial infections. Atelectasis isn't an infection, it's a mechanical problem. Collapsed tissue, not infected tissue. Nebulized bronchodilators dilate narrowed airways for conditions like asthma or COPD. Atelectasis is about collapsed alveoli, not constricted bronchi. CPAP, continuous positive airway pressure, is reserved for more severe respiratory failure or sleep apnea. For routine post-operative atelectasis, incentive spirometry is the first move. Here's a WGU D443 OA exam tip for you. Post-operative shallow breathing plus diminished breath sounds plus dull percussion equals atelectasis, and the intervention is incentive spirometry. Quick recall hook. Surgery makes breathing shallow. Shallow breathing collapses alveoli. The spirometer opens them back up. Surgery, shallow, spirometer. 21. A student nurse prepares to measure blood pressure on an obese patient and selects a standard adult-sized cuff that appears too small for the arm. The instructor explains that using a cuff too small will produce an inaccurate result. Which measurement error would this cause? A. A falsely low systolic reading result. B. An absent Korotkoff sound altogether. C. A falsely high blood pressure reading. D. an irregular pulse rhythm detection error. Can you guess the answer? Correct answer, C. A falsely high blood pressure reading. Explanation: option C is correct because a blood pressure cuff that is too small for the arm will not adequately compress the brachial artery, resulting in a falsely elevated blood pressure reading during measurement. Option A is incorrect because a cuff that is too small actually produces falsely high readings rather than falsely low ones. A cuff that is too large would produce falsely low blood pressure results. Option B is incorrect because carot cough sounds will still be audible when using an incorrectly sized cuff, although the blood pressure values recorded from those sounds will be inaccurately elevated due to compression. Option D is incorrect because blood pressure cuff size has no effect on detecting pulse rhythm irregularities, since irregular rhythms are identified through palpation or cardiac auscultation independently of cuff sizing. This is one of those questions where knowing one simple rule saves you every time. The scenario: a student nurse picks up a standard adult blood pressure cuff for an obese patient, and it's clearly too small for the arm. What happens? You get a falsely high reading. Here's the mechanics behind it. A blood pressure cuff works by inflating around the arm to compress the brachial artery and temporarily stop blood flow. Then the cuff slowly deflates, and you listen for carot cough sounds. Those are the tapping sounds that mark your systolic and diastolic readings. If the cuff is too small, it can't distribute pressure evenly across the full width of the arm. It doesn't compress the artery properly, so you have to inflate it higher to occlude the artery, and the reading comes back artificially elevated. Too small equals falsely high. The reverse is also testable. A cuff that's too large spreads pressure over too wide an area and gives a falsely low reading. The other options miss the point. Carot cough sounds don't disappear. They're still audible, just at the wrong values. Pulse rhythm irregularities are detected through palpation or cardiac monitoring, not through cuff sizing. And a falsely low reading is what a too large cuff produces, not a too small one. Here's a WGU D443 OA exam tip for you. Small cuff equals falsely high, large cuff equals falsely low. The cuff size and the error go in opposite directions. Quick recall hook: small squeezes too hard, pressure reads too high. Think of a tight bracelet squeezing your wrist. 22. A nurse needs to assess the heart rate of a newborn infant during a routine well baby examination. Standard clinical practice for measuring heart rate in this age group requires a technique that differs from the method commonly used for adult patients. Which method is most appropriate for this infant? A. Palpate the radial pulse for 60 seconds. B. Auscultate apical pulse for 1 full minute. C. Count the carotid pulse for 30 seconds. D. Palpate the femoral pulse for 60 seconds. What do you think is the answer? Correct answer: B. Auscultate apical pulse for 1 full minute. Explanation: option B is correct because auscultating the apical pulse for a full 60 seconds using a stethoscope placed over the cardiac apex is the recommended standard method for accurately assessing heart rate in newborn infants. Option A is incorrect because the radial pulse in newborn infants is very difficult to reliably palpate due to their extremely small wrist size, making this an inaccurate and unreliable method for this age group. Option C is incorrect because palpating the carotid pulse is not the standard recommended practice for newborn infants, and counting for only 30 seconds may miss subtle rhythm irregularities that a full minute would detect. Option D is incorrect because while the femoral pulse can assess lower extremity circulation, it is not the established standard method recommended specifically for routine heart rate measurement in newborn infants during examinations. How do you measure heart rate in a newborn? Not the same way you do for an adult. The answer is auscultating the apical pulse for 1 full minute. In adults, you might grab a radial pulse and count for 30 seconds. In newborns, that doesn't work. Their wrists are tiny. Their radial arteries are extremely small, and palpating a reliable radial pulse is unreliable at best. The standard practice is to place the stethoscope over the cardiac apex. That's the point of maximal impulse on the left chest. And listen for one full 60 seconds. Why a full minute? Because newborn heart rates are fast and can be irregular, and counting for a shorter period and multiplying introduces error. 60 seconds gives you the most accurate count. The carotid pulse isn't standard for newborns either, and counting for only 30 seconds could miss irregularities. The femoral pulse can assess circulation to the lower extremities, but it's not the go-to method for routine heart rate measurement in this population. Here's a WGU D443 OA exam tip for you. Infant heart rate equals apical pulse for 60 seconds. Anytime a question says newborn or infant and asks about heart rate method, the answer is apical auscultation for a full minute. Quick recall hook. Babies are small, so listen to the heart directly. Apical for a full minute. That's the baby rule. 23. A nurse assessing a healthy adult patient records an oral temperature in the early morning that is noticeably lower than the reading from the previous late afternoon visit. The patient reports no illness and no new medications. Which factor best explains this normal temperature variation? A. Food intake raises temperature after meals. B. Hospital anxiety elevates the reading. C. Medication effects alter baseline values. D. Diurnal cycle produces normal daily changes. Can you guess the answer? Correct answer. D. Diurnal cycle produces normal daily changes. Explanation. Option D is correct because the diurnal cycle produces normal predictable body temperature variations throughout each day, with the lowest readings occurring in the early morning hours and the highest readings happening in late afternoon. Option A is incorrect because although eating may cause a slight temporary temperature increase, this does not explain the consistent pattern of lower morning and higher afternoon readings, characteristic of the normal diurnal cycle. Option B is incorrect because although anxiety can transiently elevate body temperature through sympathetic nervous system activation, this would not create a consistent, predictable pattern of lower morning and higher afternoon readings seen each day. Option C is incorrect because medication side effects would typically produce unpredictable or variable temperature changes rather than the consistent and predictable daily pattern of lower morning and higher afternoon readings from normal diurnal rhythm. A patient's temperature is lower in the early morning and higher in the late afternoon. No illness, no meds. What explains it? The diurnal cycle. Your body temperature isn't a fixed number. It fluctuates predictably throughout the day following a circadian rhythm. The lowest point hits in the early morning hours, roughly between 4 and 6 a.m., and the peak happens in the late afternoon and early evening. This is completely normal physiology, not a sign of illness. The variation can be about 1 degree Fahrenheit. The other answers try to explain the difference but fall short. Food intake can bump temperature slightly after a meal, but that doesn't explain a consistent morning low and afternoon high pattern day after day. Anxiety might transiently raise temperature, but again, it doesn't create a predictable daily rhythm. Medication effects would typically produce irregular or unpredictable changes, not this clean circadian pattern. Here's a WGU D443 OA exam tip for you. When a question describes lower morning temperature and higher afternoon temperature in a healthy patient, the answer is diurnal variation. Quick recall hook. Diurnal sounds like diurnal. Think of the day cycle. Low in the AM, high in the PM. Your body wakes up cold and warms through the day. 24. An elderly patient stands up from a seated position and immediately reports feeling dizzy and lightheaded. The nurse rechecks vital signs and finds a significant drop in systolic blood pressure compared to the seated reading taken moments before. Which condition does this finding indicate? A. Orthostatic hypertension from position change. B. Essential hypertension from arterial stiffness. C. Cardiac tamponade from pericardial fluid. D. supine hypertension from volume overload? Do you know the answer? Correct answer. A. Orthostatic hypertension from position change. Explanation. Option A is correct because orthostatic hypertension is specifically defined by a significant systolic blood pressure drop upon standing that causes dizziness and lightheadedness from temporarily reduced cerebral blood flow during the position change. Option B is incorrect because essential hypertension involves persistently elevated blood pressure readings and does not typically produce a significant drop in systolic pressure specifically triggered by changing from a seated to a standing position. Option C is incorrect because cardiac tamponade involves fluid compressing the heart within the pericardial sac, causing persistent hypertension and muffled heart sounds, not a position-dependent blood pressure drop that occurs only upon standing. Option D is incorrect because supine hypertension refers to elevated blood pressure, while the patient is lying down and does not describe the significant position-dependent systolic pressure drop when this patient stands. Patient stands up from a chair, immediately feels dizzy, and the nurse finds a significant drop in systolic blood pressure compared to the seated reading. That's orthostatic hypertension. Orthostatic means related to standing upright. Hypertension means low blood pressure. Put them together. Blood pressure drops when you stand. Normally your body compensates when you stand up. Baroreceptors sense the pressure change and trigger vasoconstriction and a slight heart rate increase to maintain cerebral perfusion. In orthostatic hypertension, that compensatory mechanism fails or is delayed. Blood pools in the legs, systolic pressure drops, and the brain gets temporarily shortchanged on blood flow. Result: dizziness and lightheadedness. The clinical definition is a systolic drop of 20 millimeters of mercury or more, or a diastolic drop of 10 or more within 3 minutes of standing. Why not the other options? Essential hypertension is persistently elevated blood pressure, the opposite problem. Cardiac tamponade causes persistent low blood pressure from fluid compressing the heart, not a position-dependent drop. Supine hypertension is high blood pressure while lying down, not a drop upon standing. Here's a WGU D443 OA exam tip for you. Dizziness upon standing plus blood pressure drop equals orthostatic hypertension. The position change is the trigger. Quick recall hook. Ortho means upright. Static means standing. Blood pressure drops when you stand up. Orthostatic. 25. A nurse performing a routine assessment on a 75-year-old patient documents a slightly irregular resting heart rate and a baseline oral temperature, measuring below standard adult normal values. The patient denies acute illness or discomfort and has no new complaints today. Which statement best explains these findings? A. Increased metabolism raises elderly temperatures. B. Enhanced vagal tone produces faster heart rates. C. Aging reduces thermoregulation and cardiac regularity. D. Improved cardiac output creates stronger pulses. Do you know the answer? Correct answer, C. Aging reduces thermoregulation and cardiac regularity. Explanation. Option C is correct because aging adults commonly experience decreased thermoregulation from reduced metabolic activity, producing lower baseline temperatures, along with cardiac conduction system changes that can cause slight pulse irregularities during assessment. Option A is incorrect because aging adults actually experience a decreased metabolic rate rather than an increased one, which is precisely why their baseline body temperatures measure lower than the standard adult normal values. Option B is incorrect because enhanced vagal tone would slow the heart rate rather than produce the irregular rhythm described, and aging typically reduces cardiac conduction efficiency rather than uniformly increasing vagal tone. Option D is incorrect because aging adults commonly experience decreased cardiac output and may develop weaker peripheral pulses from progressive arterial stiffening, not the improved cardiac output or stronger pulse findings suggested here. A 75-year-old patient has a slightly irregular heart rate and a baseline temperature that's below the normal adult range. No illness. No complaints. What's going on? Aging. As people get older, two things happen that explain these findings. First, thermoregulation declines. Metabolic rate slows down with age, which means less internal heat production. That's why elderly patients commonly run lower baseline temperatures. Second, the cardiac conduction system accumulates changes over decades. Fibrosis and calcification in the conduction pathways can produce slight irregularities in the heart rhythm without any acute pathology. Both findings together are considered normal, age-related changes. The wrong answers get the physiology backwards. Increased metabolism raising temperature? No. Metabolism decreases with age, which is precisely why their temperatures are lower. Enhanced vagal tone, producing faster heart rates. Vagal tone slows the heart. It doesn't speed it up, and aging actually reduces conduction efficiency. Improved cardiac output with stronger pulses? Cardiac output typically decreases with age, and arterial stiffening can weaken peripheral pulses. Here's a WGU D443 OA exam tip for you. When a question gives you an elderly patient with lower temperature and slightly irregular pulse but no acute illness, think normal aging changes. Quick recall hook: old and cold with an irregular fold. Aging slows metabolism and conduction both. 26. A nursing student is preparing to perform a complete abdominal assessment on a patient complaining of generalized stomach discomfort. The instructor reminds the student that the abdominal examination follows a unique sequence that differs from other body system assessments. Which order of techniques is correct for the abdomen? A. Palpation, then percussion, then auscultation. B. Inspection, then auscultation, then percussion. C. Auscultation, then inspection, then palpation. D. Percussion, then palpation, then inspection. Do you know the answer? Correct answer: B. Inspection, then auscultation, then percussion. Explanation: option B is correct because the abdominal exam uniquely requires auscultation before percussion and palpation, since touching the abdomen first can alter bowel sounds and produce inaccurate auscultation findings during the assessment. Option A is incorrect because palpating the abdomen before auscultating can stimulate or alter bowel motility and sounds, which would compromise the accuracy of auscultation findings obtained later in the examination sequence. Option C is incorrect because auscultation must follow inspection, not to precede it. The correct sequence begins with visual inspection of the abdomen for distension, scars, and symmetry before any other technique. Option D is incorrect because percussion and palpation, performed before auscultation, would stimulate the bowel and change motility patterns, making subsequent auscultation of bowel sounds inaccurate and clinically unreliable for assessment. The abdominal exam is the oddball of physical assessment because it breaks the normal sequence. Everywhere else on the body you follow inspection, palpation, percussion, auscultation. For the abdomen, inspection, auscultation, percussion, palpation. Auscultation moves to second. The reason is practical and important. If you palpate or percuss the abdomen before you listen, you physically stimulate the bowel. That stimulation can speed up or alter bowel motility, which changes the sounds you hear. So you'd be listening to artificially altered bowel sounds instead of the patient's true baseline. By listening first, before you touch anything, you get an accurate read on bowel sound frequency and character. Option A puts palpation first, which would stimulate the bowel before listening. Option C has auscultation before inspection, but you always start with inspection to look for distension, scars, and asymmetry. Option D puts percussion and palpation before auscultation. Same problem as option A. Here's a WGU D443 OA exam tip for you. The abdomen is the only system where auscultation comes before percussion and palpation. If a question asks about abdominal exam sequence, remember the rule: listen before you touch. Quick recall hook. Abdomen equal sign auscultate before touching. AB for abdomen, AB for auscultate before. 27. A patient reports severe abdominal pain that began near the umbilicus and migrated to the lower right quadrant. The nurse palpates and finds sharp tenderness at a landmark located 1/3 the distance from the hip to the navel. Which condition best matches these findings? A. Cholecystitis with gallbladder inflammation. B. Peptic ulcer disease with gastric erosion. C. Pancreatitis with enzyme activation damage. D. Acute appendicitis with McBurney point pain. Can you guess the answer? Correct answer. D. Acute appendicitis with McBurney point pain. Explanation. Option D is correct because acute appendicitis classically presents with periumbilical pain migrating to the right lower quadrant, with sharp tenderness at McBurney point located 1/3 the distance from hip to navel. Option A is incorrect because cholecystitis presents with right upper quadrant pain, nausea, and a positive Murphy sign during deep inspiration, not the right lower quadrant pain and McBurney point tenderness described here. Option B is incorrect because peptic ulcer disease typically causes epigastric burning pain that worsens on an empty stomach, not the migratory pain pattern ending in the right lower quadrant with McBurney point tenderness. Option C is incorrect because pancreatitis presents with severe epigastric pain, often radiating to the back, along with nausea and elevated enzyme levels, not right lower quadrant tenderness at McBurney anatomical point. Pain that starts near the belly button and migrates to the right lower quadrant, with sharp tenderness at a point 1/3 the distance from the hip to the navel. That's textbook acute appendicitis with McBurney point tenderness. The appendix sits in the right lower quadrant, and when it becomes inflamed, the pain follows a classic migration pattern. It often begins as a vague ache around the umbilicus, because the visceral afferent nerves from the appendix initially refer pain to the periumbilical region. As inflammation worsens and reaches the peritoneum, the pain localizes to the right lower quadrant, specifically at McBurney point. McBurney point is an anatomical landmark, exactly 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Sharp tenderness at this spot is a hallmark sign. The other conditions have completely different pain locations. Cholecystitis hits the right upper quadrant with a positive Murphy sign. Peptic ulcer causes epigastric burning, often related to meals. Pancreatitis produces severe epigastric pain that radiates to the back. None of these match the right lower quadrant presentation described. Here's a WGU D443 OA exam tip for you. Periumbilical pain migrating to the right lower quadrant plus McBurney point tenderness equals appendicitis. That migration pattern is the giveaway. Quick recall hook. McBurney is where the appendix burns. Pain starts at the belly button and burns its way down to McBurney point. 28. A patient reports sharp right upper quadrant pain, worsening after fatty foods, with nausea and fever. The nurse palpates the right upper quadrant and asks the patient to breathe deeply, which causes the patient to abruptly stop inhaling. Which clinical sign does this represent? A. A positive Murphy sign for gallbladder disease. B. A positive Rovsing sign for appendix inflammation. C. A positive Blumberg sign for peritoneal irritation. D. A positive McBurney sign for appendiceal tenderness. What do you think is the answer? Correct answer, A. A positive Murphy sign for gallbladder disease. Explanation. Option A is correct because Murphy sign is elicited when palpation of the right upper quadrant during deep inspiration causes the patient to abruptly stop breathing due to the inflamed gallbladder contacting the examiner hand. Option B is incorrect because Rovsing sign involves pain felt in the right lower quadrant when pressure is applied to the left lower quadrant, which is used to assess for appendicitis rather than gallbladder inflammation. Option C is incorrect because Blumberg sign refers to rebound tenderness felt when the examiner quickly releases pressure from the abdomen, indicating peritoneal irritation, not the inspiratory arrest described in this scenario. Option D is incorrect because McBurney sign refers to point tenderness at a specific location in the right lower quadrant associated with appendicitis, not the right upper quadrant inspiratory pain described during this assessment. Right upper quadrant pain after fatty foods, nausea, fever, and during palpation the patient suddenly stops breathing in when the nurse pushes on the RUQ. That's a positive Murphy sign, and it points straight to gallbladder disease, cholecystitis. Murphy sign works like this. The nurse places their hand below the right coastal margin in the right upper quadrant. They ask the patient to take a deep breath. As the diaphragm pushes the liver and gallbladder downward during inspiration, the inflamed gallbladder contacts the examiner's hand. The contact is so painful that the patient instinctively stops inhaling mid-breath. That abrupt inspiratory arrest is what defines a positive Murphy sign. The wrong options test other abdominal signs. Rovsing sign is for appendicitis. You press the left lower quadrant, and pain is felt in the right lower quadrant. Blumberg sign is rebound tenderness. You push slowly on the abdomen, then quickly release, and pain on release signals peritoneal irritation. McBurney sign is point tenderness at the McBurney point in the right lower quadrant, also for appendicitis. All three are right lower quadrant signs. Murphy is the right upper quadrant gallbladder sign. Here's a WGU D443 OA exam tip for you. RUQ pain after fatty food plus inspiratory arrest on palpation equals Murphy sign equals cholecystitis. Quick recall hook. Murphy stops your breath, just like the patient stops inhaling mid-breath during the test. 29. A nurse auscultates the abdomen of a post-operative patient and hears no bowel sounds after listening carefully for an extended period across all quadrants. The patient had abdominal surgery 2 days ago and has not passed gas. Which finding does this most likely indicate? A. Hyperactive bowel motility from diarrhea. B. Normal expected post-operative bowel activity. C. Paralytic ileus with absent bowel motility. D. Mechanical bowel obstruction with blockage. Can you guess the answer? Correct answer, C. Paralytic ileus with absent bowel motility. Explanation: Option C is correct because absent bowel sounds following abdominal surgery strongly suggest paralytic ileus, a temporary cessation of normal bowel peristalsis that commonly occurs as a post-operative complication after abdominal procedures. Option A is incorrect because hyperactive bowel sounds would present as frequent, loud, high-pitched rushing or gurgling sounds during auscultation, which is the opposite of the complete absence of bowel sounds described here. Option B is incorrect because while reduced bowel sounds may be expected shortly after surgery, a complete absence of bowel sounds combined with no flatus passage indicates an abnormal post-operative complication requiring clinical attention. Option D is incorrect because mechanical bowel obstruction typically produces high-pitched, hyperactive, tinkling bowel sounds above the obstruction site rather than the complete silence and absent sounds described in this patient assessment. Post-operative patient. Day 2 after abdominal surgery. No bowel sounds after extended listening across all quadrants, and no flatus. That's paralytic ileus. Paralytic ileus is a temporary shutdown of normal bowel peristalsis. It's a common complication after abdominal surgery because the handling of the bowel during the procedure, anesthesia, and opioid pain medications can all temporarily paralyze the intestinal smooth muscle. The bowel just stops moving. You listen and hear silence. No clicks, no gurgles, nothing. The key distinction here is between absent sounds and hyperactive sounds. Hyperactive bowel sounds, frequent, loud, high-pitched rushing or gurgling, would point toward diarrhea or early mechanical obstruction. This patient has the opposite: silence. Normal post-op activity would show some reduced bowel sounds, but complete absence plus no gas passage is abnormal. Mechanical obstruction produces high-pitched tinkling sounds above the blockage point, also different from silence. Here's a WGU D443 OA exam tip for you. Post-abdominal surgery plus completely absent bowel sounds plus no flatus equals paralytic ileus. The word paralytic tells you everything. The bowel is paralyzed. Quick recall hook. Paralytic ileus, the bowel is paralyzed after surgery. No movement, no sound, no gas. 30. A nurse performs abdominal percussion during a routine physical examination. When percussing over the stomach and intestines, the nurse expects to hear a specific sound produced by air within the hollow gastrointestinal organs. Which percussion note is considered normal over these areas? A. Dullness indicating solid organ tissue. B. Flatness indicating dense bone structure. C. Hyperresonance indicating trapped excess air. D. Tympany indicating air in hollow organs. What do you think is the answer? Correct answer: D. Tympany indicating air in hollow organs. Explanation: Option D is correct because tympany is the normal percussion sound heard over air-filled hollow organs like the stomach and intestines, producing a drum-like quality that indicates the expected presence of gas. Option A is incorrect because dullness is the percussion note heard over solid organs like the liver or fluid-filled areas, and hearing dullness over the stomach or intestines would suggest an abnormal finding. Option B is incorrect because flatness is the percussion note produced over very dense structures like bone or large muscle masses, not over the air-containing hollow organs of the gastrointestinal tract during abdominal examination. Option C is incorrect because hyperresonance indicates an excessive amount of trapped air, which may suggest abnormal conditions like a pneumothorax in the chest, and is not the expected normal finding over abdominal organs. When you percuss over the stomach and intestines, what sound do you expect to hear? Tympany. Tympany is a drum-like hollow sound produced by percussing over air-filled structures. The stomach and intestines normally contain gas, so tympany is the expected finding over most of the abdomen. Think of it like tapping on a drum. The air inside creates that resonant, hollow tone. Each percussion note tells you what's underneath your fingers. Dullness is what you hear over solid organs like the liver or over fluid collections, a short, thud-like sound. If you heard dullness over the stomach or intestines, that would be abnormal and might suggest a mass or fluid where air should be. Flatness is even more extreme. That's the sound over very dense structures, like bone or large muscle groups. Hyperresonance means too much air, more than expected. You'd hear that over a pneumothorax in the chest. Trapped air where it shouldn't be. Over the abdomen, tympany is normal. Hyperresonance would suggest abnormal distension. Here's a WGU D443 OA exam tip for you. Air-filled hollow organs produce tympany on percussion. Solid organs produce dullness. If a question asks about normal percussion over the stomach or intestines, tympany is always the answer. Quick recall hook. Tympany sounds like timpani, the drum. Air inside the gut makes a drum sound when you tap. 31. A nurse palpates the thyroid gland during a routine neck assessment and detects noticeable enlargement. The nurse auscultates over the enlarged thyroid using the stethoscope bell and hears a whooshing sound over the gland. Which condition does this finding combination most likely suggest? A. Hypothyroidism with increased gland vascularity. B. Hypothyroidism with decreased metabolic function. C. Thyroid cancer with a suspicious solid nodule. D. Goiter from chronic iodine deficiency alone. Do you know the answer? Correct answer: A. Hypothyroidism with increased gland vascularity. Explanation: Option A is correct because an enlarged thyroid gland producing a bruit on auscultation indicates increased blood flow and vascularity, which is characteristic of hyperthyroidism where the gland is hyperactive and metabolically overdriven. Option B is incorrect because hypothyroidism involves decreased thyroid function with a slowed metabolic rate. And while the gland may enlarge, it would not produce a bruit because blood flow is not significantly increased. Option C is incorrect because thyroid cancer typically presents as a firm, fixed, irregular nodule found during palpation, and a diffusely enlarged gland with an audible bruit is more characteristic of hyperthyroidism. Option D is incorrect because iodine deficiency, goiter, involves thyroid enlargement, but does not typically produce an audible bruit, since the increased vascularity causing the whooshing sound is specifically associated with hyperthyroid states. Enlarged thyroid plus a whooshing sound heard through the stethoscope over the gland. That combination points to hyperthyroidism. When the thyroid is in overdrive, producing too much thyroid hormone, the gland becomes hyperactive and its blood supply increases dramatically. All that extra blood rushing through the enlarged gland creates turbulent flow, and that turbulence produces a bruit, the whooshing sound you pick up with the bell of the stethoscope. It's the same principle as a bruit over the carotid, just in a different location. The other options don't produce this combination. Hypothyroidism means the gland is underactive. It might enlarge, but blood flow isn't ramped up, so no bruit. Thyroid cancer typically shows up as a firm, fixed, irregular nodule, not diffuse enlargement with a bruit. Iodine deficiency goiter causes the gland to enlarge as it tries to compensate for lack of iodine. But again, blood flow isn't significantly increased enough to generate an audible bruit. The bruit is the distinguishing feature. Enlargement alone has multiple causes. Enlargement plus bruit narrows it down to the hyperactive, hypervascular state of hyperthyroidism. Here's a WGU D443 OA exam tip for you. Enlarged thyroid plus bruit equals hyperthyroidism. The bruit means increased blood flow, and increased blood flow means the gland is overworking. Quick recall hook. Hyperthyroid equals sign hyperblood flow equals sign bruit you can hear. Hyper means more of everything. 32. A nurse assesses a patient with sudden one-sided facial drooping, inability to close the eye, and inability to raise the eyebrow on the affected side. All areas of that side are involved. The nurse suspects peripheral nerve injury. Which cranial nerve is most likely affected? A. Cranial nerve 5, the trigeminal nerve. B. Cranial nerve 12, the hypoglossal nerve. C. Cranial nerve 7, the facial nerve. D. Cranial nerve 10, the vagus nerve. What do you think is the answer? Correct answer. C. Cranial nerve 7, the facial nerve. Explanation. Option C is correct because cranial nerve 7 controls facial muscle movement, and complete one-sided paralysis, including the forehead, indicates a peripheral lesion, like Bell palsy rather than a central stroke. Option A is incorrect because cranial nerve 5 is the trigeminal nerve, which controls facial sensation and chewing muscles, not the voluntary facial muscle movements that are impaired in this patient presenting with drooping. Option B is incorrect because cranial nerve 12 is the hypoglossal nerve, which controls tongue movement and protrusion, and damage to this nerve would not cause the facial drooping and eye closure difficulty described here. Option D is incorrect because cranial nerve 10 is the vagus nerve, which controls swallowing, voice production, and parasympathetic functions, not the voluntary facial muscle movements that are paralysed on one side here. One-sided facial drooping, can't close the eye, can't raise the eyebrow, all on the same side, and all areas of the face are affected. The nurse suspects a peripheral nerve injury. Which cranial nerve? Cranial nerve 7, the facial nerve. CN7 controls the muscles of facial expression. It's responsible for smiling, frowning, closing the eyes and raising the eyebrows. When damaged peripherally, like in Bell palsy, the entire half of the face drops. That means both the upper face and lower face on the affected side are paralysed. This is a critical distinction from a central lesion like a stroke. In a stroke, the forehead is often spared because it receives bilateral innervation from both hemispheres. In a peripheral CN7 lesion, everything goes, forehead included. The wrong answers involve different cranial nerves. CNV, the trigeminal nerve, handles facial sensation and chewing muscles, not the expression muscles that are drooping. CNW, the hypoglossal nerve, controls the tongue. Tongue deviation, not facial droop. CNX, the vagus nerve, controls swallowing, voice and parasympathetic functions. Nothing to do with facial muscle movement. Here's a WGU D443 OA exam tip for you. Facial droop affecting the entire half of the face, including the forehead, equals peripheral CN7 lesion. If the forehead is spared, think central stroke. Quick recall hook. 7 controls the face, 7 days in a week. Your face shows every day of it. CN7 equals sign facial expressions. 33. A nurse palpates the cervical lymph nodes of a patient who recently recovered from a throat infection. Several nodes along the neck feel enlarged and mildly tender during examination. The nurse recognises findings consistent with a recent infectious process. Which characteristic best indicates a benign reactive lymph node? A. Fixed, immovable and rock-hard texture. B. Mobile, tender and soft on palpation. C. Irregularly shaped with matted clusters. D. Painless, enlarged and firmly attached. Can you guess the answer? Correct answer. B. Mobile, tender and soft on palpation. Explanation. Option B is correct because benign reactive lymph nodes responding to a recent infection are typically mobile, tender and soft to palpation, and they gradually return to normal size once the infectious process resolves. Option A is incorrect because fixed, immovable and rock-hard lymph nodes are concerning characteristics that may suggest malignancy, rather than a benign reactive response to a recent infection in the throat area. Option C is incorrect because irregularly shaped and matted lymph node clusters suggest a more serious pathological process, such as lymphoma or metastatic disease, rather than a normal, benign reactive response to recent infection. Option D is incorrect because painless, firmly attached and enlarged lymph nodes are suspicious findings that warrant further investigation for possible malignancy, not the expected benign response to a recent infectious process. Patient recently recovered from a throat infection, and the nurse finds enlarged, tender cervical lymph nodes. Which characteristics suggest these nodes are benign and reactive rather than malignant, mobile, tender and soft? When the immune system fights an infection, nearby lymph nodes swell up as they ramp up their immune response. These reactive nodes are characteristically mobile. They slide under your fingers during palpation. They're tender because the rapid swelling stretches the capsule, and they feel soft, not rock hard. They'll gradually shrink back to normal once the infection resolves. Malignant lymph nodes behave differently. Fixed and immovable nodes suggest the cancer has invaded surrounding tissue, anchoring the node in place. Rock-hard texture is a red flag for malignancy. Matted clusters, where nodes feel stuck together in irregular clumps, suggest lymphoma or metastatic spread. Painless, firm and attached nodes are another warning sign that something more serious than an infection is going on. Here's a WGU D443 OA exam tip for you. Benign reactive nodes from infection are mobile, tender and soft. Malignant nodes are fixed, hard, painless and sometimes matted. The tenderness is actually the reassuring sign. It suggests infection, not cancer. Quick recall hook. Friendly nodes are soft and move. Dangerous nodes are hard and stay put. 34. A paediatric nurse is assessing a 6-month-old infant and palpates the anterior fontanelle during the head examination. The nurse finds that the fontanelle feels tense and is visibly bulging above the surrounding skull bones when the infant is calm and upright. Which condition does this finding most likely indicate? A. normal expected finding for this age. B, possible dehydration causing fluid loss. C, premature fontanelle closure from fusion. D, increased intracranial pressure in the infant. Do you know the answer? Correct answer, D, increased intracranial pressure in the infant. Explanation. Option D is correct because a tense, bulging anterior fontanelle in a calm, upright infant is a significant clinical sign indicating increased intracranial pressure, which requires immediate further evaluation and possible emergency intervention. Option A is incorrect because a normal anterior fontanelle in a calm, upright infant should feel flat and soft, not tense and bulging above the surrounding skull bones, making this finding abnormal and clinically significant. Option B is incorrect because dehydration in an infant would cause the fontanelle to appear sunken or depressed below the surrounding bone level, which is the opposite of the tense and bulging fontanelle described here. Option C is incorrect because premature fontanelle closure, known as craniosynostosis, would present as an absent or very small fontanelle that cannot be palpated, not a tense and visibly bulging fontanelle above the skull. A 6-month-old infant with a tense, bulging anterior fontanelle while calm and upright. This is a red flag for increased intracranial pressure. The fontanelles are the soft spots on an infant's skull where the cranial bones haven't fused yet. The anterior fontanelle is the larger one at the top of the head, and it normally closes between 12 and 18 months of age. When you palpate a normal fontanelle on a calm, upright infant, it should feel flat and soft. A bulging, tense fontanelle means something is pushing outward from inside the skull. Increased pressure from conditions like hydrocephalus, meningitis, or intracranial hemorrhage. This is an emergency finding. The calm and upright part of the description matters because a fontanelle can temporarily bulge during crying or when the infant is lying flat. But if it's tense and bulging while the baby is calm and upright, that eliminates those normal causes. The other options are wrong in opposite ways. A normal fontanelle is flat and soft, not tense and bulging. Dehydration causes a sunken fontanelle, the opposite of bulging. Premature closure, called craniosynostosis, means the fontanelle would be absent or too small to palpate, not bulging. Here's a WGU D443 OA exam tip for you. Bulging fontanelle in a calm, upright infant equals increased intracranial pressure. Sunken fontanelle equals dehydration. The direction of the fontanelle tells the story. Up means pressure, down means dry. Quick recall hook. Bulging up equals sign pressure up inside the skull. 35. A patient describes experiencing a severe, throbbing, one-sided headache accompanied by nausea, sensitivity to bright lights, and visual disturbances that appeared before the pain started. The headaches occur periodically and are sometimes triggered by certain foods or hormonal changes in the body. Which type of headache best matches this description? A. Migraine with characteristic aura symptoms. B. Tension headache from muscle tightness. C. Cluster headache around the eye area. D. Sinus headache from nasal cavity pressure. Can you guess the answer? Correct answer, A. Migraine with characteristic aura symptoms. Explanation. Option A is correct, because migraines classically present with unilateral throbbing pain, nausea, photophobia, and visual aura preceding the headache, often triggered by hormonal changes, certain foods, or environmental stress factors. Option B is incorrect because tension headaches present as bilateral band-like pressure around the head with mild to moderate intensity and are not associated with nausea, visual aura, or the throbbing unilateral pain described. Option C is incorrect because cluster headaches cause severe unilateral pain, specifically around or behind one eye, accompanied by tearing and nasal congestion, but they do not produce the visual aura or nausea pattern described. Option D is incorrect because sinus headaches produce pressure and pain over the forehead, and cheekbones associated with nasal congestion and sinus infection. Not the throbbing unilateral pain with visual aura and photophobia. Severe, throbbing, one-sided headache with nausea, light sensitivity, and visual disturbances that appeared before the pain started. Periodic episodes, sometimes triggered by foods or hormones. That's a migraine with aura. Migraines are vascular headaches. They involve changes in blood vessel diameter and neurochemical cascades in the brain. The hallmark features are unilateral throbbing pain, nausea or vomiting, photophobia and phonophobia. When visual disturbances like flashing lights, zigzag lines or blind spots occur before the headache, that's called an aura. Aura typically lasts 5 to 60 minutes, and then the headache follows. Common triggers include certain foods like chocolate, aged cheese or red wine, hormonal fluctuations, especially around menstruation, stress, and sleep pattern changes. The other headache types have distinct presentations. Tension headaches produce bilateral band-like pressure, like a tight band around the head. Moderate intensity, no nausea, no aura. Cluster headaches are severe and unilateral, but specifically centered around or behind one eye, with tearing and nasal congestion on the same side. No aura. Sinus headaches come with facial pressure over the forehead and cheekbones, nasal congestion, and signs of sinus infection. Here's a WGU D443 OA exam tip for you. Unilateral throbbing plus nausea plus photophobia plus aura equals migraine. The aura is the distinguishing feature that separates migraine from all other headache types. Quick recall hook. Migraine has an aura. It announces itself before it arrives. 36. A nurse assesses a patient who reports chronic knee pain worsening with physical activity and improving with rest. The pain affects one knee only, and the patient denies morning stiffness lasting longer than 30 minutes. Which condition best matches these clinical findings? A. Rheumatoid arthritis with autoimmune damage. B. Gout with uric acid, crystal deposits. C. Osteoarthritis from wear and tear damage. D. Systemic lupus with joint inflammation. Can you guess the answer? Correct answer. C. Osteoarthritis from wear and tear damage. Explanation. Option C is correct because osteoarthritis is characterized by asymmetric joint pain that worsens with activity and improves with rest, with minimal morning stiffness lasting less than 30 minutes, matching this patient presentation. Option A is incorrect because rheumatoid arthritis typically presents with symmetric joint involvement affecting both sides of the body, along with prolonged morning stiffness lasting more than 1 hour, which does not match this scenario. Option B is incorrect because gout presents with sudden severe pain, redness, and swelling in a single joint, often the big toe, from uric acid crystal deposits rather than the gradual activity-related pain described. Option D is incorrect because systemic lupus erythematosus causes widespread symmetric joint inflammation, accompanied by systemic symptoms such as fatigue, skin rashes, and organ involvement beyond the single joint pain described here. Chronic knee pain that worsens with activity and improves with rest affects only one knee and morning stiffness lasting less than 30 minutes. That pattern is osteoarthritis. Osteoarthritis is the wear and tear form of arthritis. Over years of use, the cartilage cushioning the joint surfaces breaks down. Bone grinds on bone, causing pain and stiffness. The pain characteristically gets worse with activity because movement loads the damaged joint, and gets better with rest because the load is removed. It's typically asymmetric, affecting one joint or one side more than the other, because wear patterns depend on use, prior injuries, and body mechanics. Morning stiffness in osteoarthritis is brief, usually under 30 minutes, as opposed to the prolonged stiffness of inflammatory arthritis. Now, the distractors. Rheumatoid arthritis is autoimmune and symmetric. It hits both sides of the body at once and comes with morning stiffness lasting over an hour. Gout is a sudden explosive joint inflammation from uric acid crystal deposits classically in the big toe. Acute and dramatic, not the gradual chronic pattern described. Systemic lupus causes symmetric joint inflammation with systemic symptoms like fatigue and rashes, not isolated unilateral knee pain with activity-related worsening. Here's a WGU D443 OA exam tip for you. Unilateral joint pain plus activity worsening plus rest improvement plus brief morning stiffness equals osteoarthritis. Quick recall hook. Osteoarthritis equals sign old age wear and tear. One joint, one side worsens with work. 37. A nurse tests muscle strength during a musculoskeletal examination by asking the patient to push against resistance with the arm. The patient moves the arm through full range of motion against gravity, but cannot overcome any resistance applied. Which muscle strength grade best describes this finding? A. Grade 2 with gravity-only movement. B. Grade 0 with no visible contraction. C. Grade 5 with full normal strength. D. Grade 3 movement against gravity only. Do you know the answer? Correct answer, D. Grade 3 movement against gravity only. Explanation. Option D is correct because grade 3 muscle strength means the patient can move the limb through full range of motion against gravity, but cannot overcome any additional resistance applied by the examiner during testing. Option A is incorrect because grade 2 muscle strength means the patient can move the limb through full range of motion only when gravity is eliminated, requiring a supported horizontal position for the movement. Option B is incorrect because grade 0 muscle strength indicates no visible or palpable muscle contraction at all, which is far more severe than the active movement against gravity described in this patient assessment. Option C is incorrect because grade 5 muscle strength represents full normal power, where the patient can move through complete range of motion and successfully overcome full resistance applied by the examiner. The patient moves the arm through full range of motion against gravity but cannot overcome any resistance. What grade is that? Grade 3. Muscle strength grading uses a 0 to 5 scale. Grade 0 means no visible contraction at all. The muscle doesn't fire. Grade 1 means you can see or feel a slight flicker of contraction, but nothing moves. Grade 2 means the patient can move the limb through full range, but only if gravity is eliminated. So you position the limb horizontally so gravity isn't a factor. Grade 3 means movement against gravity is possible through the full range, but when the examiner pushes against the limb, the patient can't overcome it. Grade 4 means the patient can resist some force, but not full resistance. Grade 5 is full normal strength. Complete range of motion against full examiner resistance. The question describes full range against gravity, but 0 resistance tolerance. That's grade 3 exactly. Grade 2 fails because the patient can fight gravity. Grade 0 fails because there's visible functional movement. Grade 5 fails because the patient can't resist anything. Here's a WGU D443 OA exam tip for you. The dividing line on the muscle strength scale is gravity. Below grade 3, the patient can't beat gravity. At grade 3 and above, they can. Grade 3 is where gravity gets conquered, but resistance still wins. Quick recall. Hook, grade 3 equals sign. Gravity is free, but resistance is the fee you can't pay. 38. A postmenopausal woman presents with a rounded upper back curvature and reports that she recently fractured her wrist after a minor fall from standing height. The nurse recognizes these findings as characteristic of a condition involving progressive bone density loss common in older women. Which condition best explains these findings? A. Osteoporosis with pathological bone fragility. B. Osteoarthritis with joint cartilage breakdown. C. Rheumatoid arthritis with autoimmune inflammation. D. Paget disease with abnormal bone remodeling. Do you know the answer? Correct answer, A. Osteoporosis with pathological bone fragility. Explanation. Option A is correct because osteoporosis causes progressive bone density loss leading to fragility fractures from minimal trauma and kyphosis of the thoracic spine, which is especially common in postmenopausal women losing estrogen. Option B is incorrect because osteoarthritis involves cartilage degeneration within joints causing pain and stiffness with activity, but it does not cause the pathological bone fragility and fractures from minimal trauma described here. Option C is incorrect because rheumatoid arthritis is an autoimmune condition causing symmetric joint inflammation and destruction, but it does not primarily cause the progressive bone density loss and fragility fractures described. Option D is incorrect because Paget disease involves abnormal bone remodeling that produces enlarged and misshapen bones, which is a different pathological process from the progressive generalized bone density loss seen in osteoporosis. Postmenopausal woman, rounded upper back curvature, wrist fracture from a minor fall. That's osteoporosis with pathological bone fragility. Osteoporosis literally means porous bones. After menopause, estrogen levels plummet. Estrogen plays a protective role in maintaining bone density. It slows down the osteoclasts that break down bone. Without it, bone resorption outpaces bone formation, and the bones become progressively thinner, weaker, and more fragile. Two classic signs show up together in this question. First, the kyphosis, that rounded upper back, sometimes called a dowager's hump. It happens because the weakened thoracic vertebrae gradually develop compression fractures and collapse forward. Second, the fragility fracture. A wrist fracture from a minor fall from standing height. Healthy bones can handle that kind of impact. Osteoporotic bones can't. The distractors are different conditions. Osteoarthritis involves cartilage breakdown in joints. Pain and stiffness, not fragility fractures. Rheumatoid arthritis is autoimmune joint inflammation. Symmetric swelling and morning stiffness, not bone density loss. Paget disease involves abnormal bone remodeling that makes bones enlarged and misshapen, a different pathology from the generalized thinning of osteoporosis. Here's a WGU D443 OA exam tip for you. Postmenopausal plus kyphosis plus fragility fracture equals osteoporosis. Estrogen loss is the driving mechanism. Quick recall hook. Osteoporous equals sign bones full of pores, like a sponge. Postmenopause makes bones porous. 39. A patient who works at a computer reports numbness and tingling in the thumb, index and middle fingers. The nurse suspects median nerve compression at the wrist and asks the patient to hold both wrists flexed for 60 seconds. Which test is the nurse performing? A. Lachman test for knee ligament stability. B. Phelan test for carpal tunnel syndrome. C. McMurray test for meniscal cartilage tear. D. Romberg test for balance and coordination. Do you know the answer? Correct answer, B. Phelan test for carpal tunnel syndrome. Explanation. Option B is correct because the Phelan test involves sustained wrist flexion for 60 seconds to reproduce numbness and tingling in the median nerve distribution, which is the standard screening test for carpal tunnel syndrome. Option A is incorrect because the Lachman test assesses the integrity of the anterior cruciate ligament in the knee by pulling the tibia forward while stabilizing the femur, which is unrelated to wrist nerve testing. Option C is incorrect because the McMurray test evaluates the knee meniscus by rotating and extending the knee joint while listening for clicks or pain, which is a lower extremity assessment unrelated to wrist problems. Option D is incorrect because the Romberg test evaluates balance and proprioception by having the patient stand with feet together and eyes closed, which assesses cerebellar function rather than median nerve compression. Patient works at a computer, has numbness and tingling in the thumb, index and middle fingers, and the nurse asks them to hold both wrists flexed for 60 seconds. That test is the Phelan test, and it screens for carpal tunnel syndrome. Carpal tunnel syndrome occurs when the median nerve gets compressed as it passes through the carpal tunnel at the wrist. The median nerve supplies sensation to the thumb, index finger, middle finger, and the lateral half of the ring finger. When you flex the wrist, the carpal tunnel narrows and puts additional pressure on an already compressed nerve. Holding that position for 60 seconds reproduces the tingling and numbness if carpal tunnel is present. That's a positive Phelan test. The other options are orthopedic tests for completely different body parts. The Lachman test assesses the anterior cruciate ligament in the knee. You pull the tibia forward while stabilizing the femur to check for excessive laxity. The McMurray test evaluates knee meniscus tears by rotating and extending the knee while checking for clicks and pain. The Romberg test has the patient stand with feet together and eyes closed to assess balance and proprioception. A cerebellar and vestibular test, nothing to do with the wrist. Here's a WGU D443 OA exam tip for you. Wrist flexion for 60 seconds, reproducing numbness in the median nerve distribution equals Phelan test for carpal tunnel. Quick recall hook. Phelan equal sign flexion. Both start with an F sound in your head. Flex the wrist, feel the numbness, that's Phelan. 40. A nursing student is reviewing joint types for an upcoming musculoskeletal examination. The student recalls that the knee, shoulder and hip all allow free movement and contain specialized fluid that lubricates the joint space. Which joint classification describes these freely movable joints? A. Fibrous joints that are fully immovable. B. Cartilaginous joints that are semi-movable. C. Synovial joints that are freely movable. D. Sutured joints found only in the skull. Do you know the answer? Correct answer, C. Synovial joints that are freely movable. Explanation. Option C is correct because synovial joints are freely movable joints containing synovial fluid that lubricates the joint space, and examples include the knee, shoulder and hip, which all allow extensive range of motion. Option A is incorrect because fibrous joints are immovable joints, where bones are connected by fibrous tissue with no joint cavity, such as skull sutures, which do not allow the free movement described. Option B is incorrect because cartilaginous joints are semi-movable joints, where bones are connected by cartilage, allowing only limited movement, such as the intervertebral discs of the spine, not the freely movable joints described. Option D is incorrect because sutured joints are a specific type of fibrous joint found in the skull where bones are fused by fibrous tissue, allowing no movement rather than the free motion described. The student is reviewing joint types and recalls that the knee, shoulder and hip allow free movement and contain lubricating fluid. What classification? Synovial joints. The musculoskeletal system has 3 joint classifications based on how much movement they allow. Synovial joints are freely movable. They're also called diarthroses. They have a joint cavity lined with a synovial membrane that produces synovial fluid. That fluid acts as a lubricant, reducing friction between the cartilage-covered bone surfaces during movement. The knee, shoulder, hip, elbow, and wrist are all synovial joints. They allow the widest range of movement in the body. Fibrous joints are the opposite, completely immovable, called synarthroses. The skull sutures are the classic example. Bones fused together by dense fibrous tissue with no joint cavity and no movement. Cartilaginous joints sit in the middle, semi-movable, called amphiarthroses. The intervertebral discs and the pubic symphysis are examples. Some movement, but limited. Sutured joints are simply a subtype of fibrous joints found specifically in the skull. Here's a WGU D443 OA exam tip for you. Freely movable plus synovial fluid plus joint cavity equals synovial joint. If it moves freely, it's synovial. Quick recall hook. Synovial equal sign synchronized movement. Fluid and free like a well-oiled machine. 41. A nurse assesses a patient who suddenly developed right-sided arm weakness, facial drooping, and difficulty speaking. The nurse recognizes these as warning signs of a life-threatening event, requiring immediate intervention using a rapid screening tool. Which assessment approach is most appropriate here? A. Glasgow Coma Scale for consciousness level. B. Romberg test for cerebellar balance function. C. Cranial nerve testing for all 12 pairs. D. Fast exam for rapid stroke identification. Do you know the answer? Correct answer. D. Fast exam for rapid stroke identification. Explanation. Option D is correct because the fast exam checks for facial drooping, arm weakness, speech difficulty, and time to call emergency services, making it the standard rapid screening tool for identifying an acute stroke. Option A is incorrect because the Glasgow Coma Scale assesses eye opening, verbal response, and motor response to determine consciousness level, but it is not the targeted rapid screening tool specifically designed for stroke identification. Option B is incorrect because the Romberg test evaluates balance and proprioception by having the patient stand with eyes closed, which is not appropriate or practical for a patient presenting with acute stroke symptoms. Option C is incorrect because a comprehensive 12-pair cranial nerve examination is too time-consuming during an acute stroke presentation, where rapid identification and emergency treatment within a narrow time window are critical. Right-sided arm weakness, facial drooping, and difficulty speaking, all sudden onset. The nurse needs a rapid screening tool. That tool is FAST. FAST is an acronym designed for exactly this situation. Quick identification of stroke, so you can get emergency treatment started within the narrow time window. F stands for face. Ask the patient to smile and check for facial drooping on one side. A stands for arms. Ask the patient to raise both arms and to check if one drifts downward. S stands for speech. Ask the patient to repeat a simple sentence and listen for slurred or garbled words. T stands for time. If any of those three are positive, it's time to call emergency services immediately. Time matters because clot-dissolving medication for ischemic stroke must be given within a specific window, and every minute of delay means more brain tissue lost. The wrong options aren't wrong as tests, they're wrong for this moment. The Glasgow Coma Scale assesses consciousness level with eye, verbal, and motor responses. It's useful, but it's not a stroke-specific screening tool. The Romberg test checks balance and proprioception. You can't ask a patient with acute weakness and speech difficulty to stand with eyes closed. A full 12-pair cranial nerve exam is thorough, but takes far too long when minutes count. Here's a WGU D443 OA exam tip for you. Sudden facial droop plus arm weakness plus speech difficulty plus needed for speed equals fast. Quick recall hook. Think fast because you need to act fast. The name is the reminder. Speed saves brain cells. 42. A nurse assesses an unconscious patient using the Glasgow Coma Scale. The patient does not open the eyes, makes only incomprehensible sounds, and shows abnormal arm flexion to painful stimulus. The nurse calculates the total score. Which score range indicates this patient needs immediate airway protection? A. A total score below 8 requires intubation. B. Score of 15 means full alertness. C. Score of 12 means mild impairment. D. Score of 10 means moderate impairment. Do you know the answer? Correct answer. A. A total score below 8 requires intubation. Explanation. Option A is correct, because a Glasgow Coma Scale total score below 8 indicates coma, and the patient cannot protect the airway, requiring immediate endotracheal intubation to prevent aspiration and ensure adequate ventilation. Option B is incorrect because a Glasgow Coma Scale score of 15 represents a fully alert and oriented patient with maximum scores in all three categories, which does not match the unconscious patient described. Option C is incorrect because a Glasgow Coma Scale score of 12 indicates only mild to moderate neurological impairment with some preserved responsiveness, which does not match the severely impaired patient described in this scenario. Option D is incorrect because a Glasgow Coma Scale score of 10 indicates moderate impairment with some meaningful responses still present, which is not consistent with the severely impaired patient described. An unconscious patient, no eye opening, incomprehensible sounds, and abnormal flexion to pain. The nurse calculates the Glasgow Coma Scale score. Let's do the math. The GCS has 3 components. Eye opening is scored 1 through 4. No eye opening gets a 1. Verbal response is scored 1 through 5. Incomprehensible sounds, meaning groaning or moaning without recognisable words, gets a 2. Motor response is scored 1 through 6. Abnormal flexion to painful stimulus, also called decorticate posturing, where the arms flex inward, gets a 3. Add them up. 1 plus 2 plus 3 equals 6. A total GCS of 6 falls below 8, which is the critical threshold. A score below 8 indicates coma, meaning the patient cannot protect their own airway. They can't cough, swallow, or maintain an open airway reliably. That means immediate intubation for airway protection is required. A score of 15 is maximum. Fully alert, oriented, and following commands. A score of 12 represents mild impairment. A score of 10 is moderate impairment. None of those match this severely compromised patient. Here's a WGU D443 OA exam tip for you. GCS below 8 means intubate, that's the magic number. Below 8 can't protect the airway, tube goes in, quick recall hook. GCS less than 8, intubate. 8 rhymes with intubate, that's your trigger. 43. A nurse tests deep tendon reflexes during a neurological examination using a reflex hammer on the patella tendon below the kneecap. The patient leg extends with a brisk response considered within normal limits. The nurse documents this using the standard grading scale. Which grade represents a normal reflex? A. Grade 0 indicating absent reflex response. B. Grade 4 indicating hyperactive clonus present. C. Grade 2 plus indicating a normal response. D. Grade 1 indicating a diminished, sluggish response. Can you guess the answer? Correct answer. C. Grade 2 plus indicating a normal response. Explanation. Option C is correct because a grade of 2 plus on the deep tendon reflex scale represents a normal expected brisk response, which is the standard baseline finding nurses document during routine neurological reflex examination. Option A is incorrect because a grade 0 indicates a completely absent reflex response with no muscle contraction detected despite proper technique, which is an abnormal finding suggesting possible nerve damage or lower motor pathology. Option B is incorrect because a grade 4 plus indicates hyperactive reflexes with involuntary rhythmic clonus, which is an abnormal finding suggesting upper motor neuron disease rather than the normal response described in this patient. Option D is incorrect because a grade 1 plus indicates a diminished or sluggish reflex response that is present but weaker than expected, which does not match the brisk normal response described here. The nurse taps the patella tendon with a reflex hammer. The leg extends briskly, and it's considered a normal response. What grade is that? Grade 2 plus. Deep tendon reflexes are graded on a 0 to 4 plus scale. Grade 0 means the reflex is completely absent. You tap and nothing happens. That's abnormal and could indicate nerve damage or lower motor neuron pathology. Grade 1 plus means the reflex is present but diminished. A sluggish, weak response. Grade 2 plus is the normal baseline, a brisk, expected response. This is what you want to see during a routine exam. Grade 3 plus means the reflex is brisker than expected, hyperactive without clonus. This could indicate upper motor neuron involvement. Grade 4 plus is the most abnormal on the high end, hyperactive reflexes with clonus, meaning involuntary rhythmic muscle contractions after the reflex is triggered. This strongly suggests upper motor neuron disease. The question describes a brisk, normal response. Grade 0 is absent. Wrong direction entirely. Grade 4 plus has clonus. Way too much. Grade 1 plus is diminished, not brisk. Only grade 2 plus matches a normal brisk response. Here's a WGU D443 OA exam tip for you. Normal deep tendon reflex equals 2+. 2 is the target. Below 2 is too little, above 2 is too much. Quick recall hook. 2+ is the normal score. Think of it like a grade of a B+. It's good. It's what you want to see. 44. A nurse suspects cerebellar dysfunction in a patient who reports feeling unsteady while walking with difficulty maintaining balance. The nurse asks the patient to stand with feet together, arms at the sides, and close both eyes for 20 seconds. Which test is the nurse performing? A. Babinski test for upper motor neuron signs. B. Romberg test for balance and proprioception. C. Weber test for hearing lateralization problems. D. Rinner test for conductive hearing loss types. Do you know the answer? Correct answer. B. Romberg test for balance and proprioception. Explanation. Option B is correct, because the Romberg test evaluates balance and proprioception by having the patient stand with feet together and eyes closed, and swaying or falling indicates cerebellar dysfunction or impaired proprioceptive function. Option A is incorrect because the Babinski test involves stroking the sole of the foot to check for upper motor neuron pathology, which is a completely different neurological assessment than the standing balance test. Option C is incorrect because the Weber test is an auditory assessment using a tuning fork on the midline of the skull to determine if hearing loss lateralizes to one side, not a balance test. Option D is incorrect because the Rinner test compares bone conduction to air conduction of sound using a tuning fork placed on the mastoid process, which assesses hearing function rather than cerebellar balance. Patient reports feeling unsteady while walking and has trouble with balance. The nurse asks the patient to stand with feet together, arms at the sides, and close both eyes for 20 seconds. That's the Romberg test. The Romberg test evaluates two things: balance and proprioception. Proprioception is your body's ability to sense where it is in space without looking. When you stand with your eyes open, you use three systems to stay balanced: your vision, your vestibular system in the inner ear, and your proprioceptive sensors in the joints and muscles. The Romberg test removes vision by closing the eyes. If the patient can stay steady with eyes closed, their proprioception and vestibular system are working fine. If they sway significantly or start to fall, that's a positive Romberg suggesting cerebellar dysfunction or impaired proprioception. The wrong options are completely different tests. The Babinski test involves stroking the bottom of the foot with a blunt instrument and watching the toes. An upward fanning of the big toe indicates upper motor neuron pathology. Nothing to do with standing balance. The Weber test uses a tuning fork placed on the top of the skull to check if hearing lateralizes to one side. An auditory test. The Rinner test compares bone conduction versus air conduction by placing a tuning fork on the mastoid bone and then near the ear. Also hearing, not balance. Here's a WGU D443 OA exam tip for you. Stand with feet together and eyes closed equals Romberg. If it involves standing and closing eyes, the answer is Romberg every time. Quick recall hook. Romberg removes your sight. Eyes closed, balance tested. Remove starts with R, Romberg starts with R. 45. A patient arrives at the emergency department within 2 hours of sudden right-sided weakness and speech difficulty. A brain scan reveals a blood clot, blocking blood flow with no evidence of bleeding. The team considers clot-dissolving medication. Which stroke type and treatment combination is most appropriate? A. Ischemic stroke treated with clot-dissolving medication. B. Hemorrhagic stroke treated with surgical blood evacuation. C. Ischemic stroke treated with blood pressure medications. D. Hemorrhagic stroke treated with clot-dissolving medication. Do you know the answer? Correct answer. A. Ischemic stroke treated with clot dissolving. Explanation. Option A is correct because an ischemic stroke caused by a blood clot blocking cerebral blood flow is treated with tissue plasminogen activator, a clot-dissolving medication, when administered within the established treatment time window. Option B is incorrect because hemorrhagic stroke involves blood vessel rupture and bleeding in the brain, and this patient scan specifically shows a clot blocking blood flow with no evidence of bleeding. Option C is incorrect because while blood pressure management is part of stroke care, the primary emergency treatment for an ischemic stroke presenting within the treatment window is clot-dissolving medication, not blood pressure medication alone. Option D is incorrect because clot-dissolving medication is absolutely contraindicated in hemorrhagic stroke since it would worsen the bleeding, and this patient has an ischemic stroke caused by a clot rather than a hemorrhage. Patient arrives within 2 hours of sudden right-sided weakness and speech difficulty. Brain scan shows a blood clot blocking flow, no bleeding. The team considers clot-dissolving medication. This is an ischemic stroke treated with tissue plasminogen activator, TPA. There are 2 types of stroke and you need to keep them straight. Ischemic stroke is caused by a blood clot blocking a cerebral artery, cutting off blood supply to brain tissue. About 87% of strokes are ischemic. The treatment is TPA, a clot-dissolving medication that breaks down the clot and restores blood flow. But it must be given within the time window, generally 4.5 hours from symptom onset, which is why this question emphasises the 2-hour arrival. Hemorrhagic stroke is caused by a blood vessel rupturing and bleeding into the brain. Treatment focuses on stopping the bleeding, controlling pressure, and potentially surgical evacuation. Here's the critical piece. TPA is absolutely contraindicated in hemorrhagic stroke. If the vessel is already ruptured and bleeding, dissolving clots would make the bleeding catastrophically worse. The scan in this question shows a clot with no bleeding. That confirms ischemic, and TPA is the right call. Blood pressure management alone isn't the primary emergency treatment for ischemic stroke when the patient qualifies for TPA. Here's a WGU D443 OA exam tip for you. Clot blocking flow plus no bleeding equals ischemic stroke equals TPA. Bleeding in the brain equals hemorrhagic stroke equals never give TPA. Quick recall, hook. Ischemic equals sign I is for I'm blocked. Equal sign clot equal sign TPA dissolves it. Hemorrhagic equal sign H is for hemorrhage. Equal sign bleeding equal sign TPA makes it worse. 46. A 60-year-old male reports difficulty starting urination, a weak urine stream, and waking multiple times at night to urinate. On digital rectal examination, the prostate is enlarged, smooth, and non-tender. The nurse suspects a common age-related condition. Which condition best matches these findings? A. Acute bacterial prostatitis with infection. B. Testicular cancer with a scrotal mass. C. Urinary tract infection with bacterial growth. D. Benign prostatic hyperplasia causing obstruction. Do you know the answer? Correct answer, D. Benign prostatic hyperplasia causing obstruction. Explanation. Option D is correct because benign prostatic hyperplasia presents with urinary hesitancy, weak stream, and nocturia in older males, with an enlarged, smooth, non-tender prostate found on digital rectal examination, confirming non-cancerous enlargement. Option A is incorrect because acute bacterial prostatitis presents with a tender, boggy prostate on examination, accompanied by fever, chills, and painful urination, not the smooth, non-tender gland described in this patient assessment. Option B is incorrect because testicular cancer presents as a painless lump found in the testicle during scrotal examination, not the urinary obstructive symptoms and enlarged prostate gland described during this rectal examination. Option C is incorrect because a urinary tract infection presents with burning during urination, urgency, and cloudy urine with positive urinalysis findings, not the mechanical obstructive symptoms and enlarged prostate described in this patient. 60-year-old male with difficulty starting urination, a weak stream, and waking up multiple times at night to pee. Digital rectal exam reveals an enlarged, smooth, non-tender prostate. That's benign prostatic hyperplasia, or BPH. BPH is extremely common in older men. The prostate gland sits right below the bladder and surrounds the urethra. As men age, the prostate gradually enlarges. When it gets big enough, it squeezes the urethra and creates a mechanical obstruction to urine flow. That's why you get hesitancy, difficulty starting the stream, and a weak flow once it does start. Nocturia, waking at night to urinate, happens because the bladder can never fully empty, so it fills up again quickly. The DRE findings are key to this question. The prostate is enlarged but smooth and non-tender. Smooth and non-tender tells you this is benign growth, not infection or cancer. Acute bacterial prostatitis would give you a tender, boggy prostate with fever, chills and painful urination. The gland would hurt when you touch it. Testicular cancer presents as a painless lump in the testicle found on scrotal exam, completely different anatomy. A urinary tract infection causes burning, urgency, and cloudy urine with positive urine cultures. Those are infectious symptoms, not mechanical obstruction symptoms. Here's a WGU D443 OA exam tip for you. Older male plus obstructive urinary symptoms plus enlarged, smooth, non-tender prostate on DRE equals BPH. The smooth and non-tender part rules out infection and cancer. Quick recall hook, BPH equals sign big prostate, hard to pee. Smooth and painless gland, just big, not bad. 47. A young female patient reports burning pain during urination, frequent urgent bathroom trips, and cloudy, foul-smelling urine. She denies fever, flank pain or vaginal discharge. The nurse suspects a lower urinary tract infection and prepares to collect a specimen. Which diagnostic test would best confirm this? A. Complete blood count with differential. B. Renal ultrasound of both kidneys. C. Urinalysis with culture and sensitivity. D. Abdominal computed tomography scan. Can you guess the answer? Correct answer, C. Urinalysis with culture and sensitivity. Explanation. Option C is correct because urinalysis with culture and sensitivity is the standard diagnostic test for confirming a urinary tract infection by detecting white blood cells, nitrites and bacteria, and identifying the specific causative organism. Option A is incorrect because a complete blood count evaluates overall blood cell counts and may show elevated white blood cells during infection, but cannot specifically confirm or identify a urinary tract infection. Option B is incorrect because a renal ultrasound visualizes kidney structure and can detect stones or obstruction, but it is not the appropriate first-line diagnostic test for confirming a straightforward lower urinary tract infection. Option D is incorrect because an abdominal computed tomography scan provides detailed organ imaging, but is not indicated as the initial diagnostic test for a simple lower urinary tract infection with typical symptoms. Young female with burning during urination, frequent urgent trips, and cloudy, foul-smelling urine. No fever, no flank pain, no vaginal discharge. The nurse suspects a lower UTI. Which test confirms it? Urinalysis with culture and sensitivity. Urinalysis with culture and sensitivity is the gold standard for confirming a urinary tract infection. The urinalysis portion detects white blood cells, red blood cells, nitrites and leukocyte esterase, all markers of infection in the urine. The culture grows the actual bacteria to identify the specific organism causing the infection. The sensitivity part tests which antibiotics the organism responds to, guiding targeted treatment. The lack of fever and flank pain is important. It tells you this is a lower UTI, confined to the bladder, not an upper UTI like pyelonephritis involving the kidneys. The wrong options are diagnostic tools used for different situations. A complete blood count checks overall blood cell counts. It might show elevated white blood cells during any infection, but it can't tell you the infection is in the urinary tract or identify the specific organism. A renal ultrasound visualizes kidney structures and can find stones or hydronephrosis, but it doesn't diagnose a straightforward bladder infection. An abdominal CT scan gives detailed imaging of organs, but is overkill for a simple lower UTI with classic symptoms. Here's a WGU D443 OA exam tip for you. Classic UTI symptoms plus need for confirmation equals urinalysis with culture and sensitivity. Culture identifies the bug, sensitivity identifies the drug. Quick recall hook, UACNS. Urine analysis culture the bug, sensitivity picks the drug. CNS go together like crime and solving it. 48. A nurse is educating a 32-year-old female patient about recommended cervical cancer screening guidelines during a wellness visit. The patient has no history of abnormal results and asks the nurse how often she should have screening performed. Which screening schedule is currently recommended for this patient age group? A. Pap with HPV test every 5 years. B. Pap smear alone performed every single year. C. HPV testing alone performed every 10 years. D. No screening needed until age 45. Do you know the answer? Correct answer, A. Pap smear with HPV testing every 5 years. Explanation. Option A is correct because current screening guidelines recommend that women aged 30 to 65 receive a Pap smear combined with HPV testing every 5 years, which is the preferred approach for this patient. Option B is incorrect because annual Pap smear screening is no longer the standard recommendation for women in this age group with no abnormal results, as guidelines have shifted to longer intervals with combined testing. Option C is incorrect because screening every 10 years is far too infrequent, according to current cervical cancer screening guidelines, which recommend the combined Pap and HPV test every 5 years for this group. Option D is incorrect because cervical cancer screening is strongly recommended starting at age 21 and continuing through age 65, so advising no screening until age 45 would be a dangerous and incorrect recommendation. A 32-year-old woman with no history of abnormal results asks how often she should get cervical cancer screening. The answer is a Pap smear combined with HPV testing every 5 years. Current clinical guidelines break cervical cancer screening into age-based recommendations. Women aged 21 to 29 get a Pap smear alone every 3 years. Women aged 30 to 65 get the preferred co-testing approach, a Pap smear combined with HPV testing every 5 years. The HPV test is added because HPV, specifically the high-risk strains like 16 and 18, is the primary cause of cervical cancer. Combining the two tests gives better detection than either one alone and allows for a safer 5-year interval between screenings. This patient is 32 with no abnormal history. She fits squarely in the 30 to 65 group. Annual Pap smears were the old standard, but guidelines moved away from that because annual screening leads to over-testing, unnecessary procedures, and patient anxiety without improving outcomes. Screening every 10 years is far too infrequent. A lot can change in a decade, and skipping screening until age 45 ignores the recommendation to start at 21, creating a dangerous gap where cancers could go undetected. Here's a WGU D443 OA exam tip for you. For women 30 to 65, the preferred screening is Pap plus HPV every 5 years. The number 5 is your target. Quick recall hook. 30 to 65, co-test every 5. The rhyme locks it in. 49. A nurse performing a clinical breast examination notices skin dimpling, nipple retraction, and a firm irregular mass in the upper outer quadrant of the left breast. These findings are new and were not present at the previous annual examination. Which action should the nurse prioritise? A. Recommend warm compresses for comfort. B. Advise monthly self-examination. Only now C. Schedule a repeat examination in 6 months. D. Refer for diagnostic imaging and immediately. Can you guess the answer? Correct answer, D. Refer for diagnostic imaging immediately. Explanation. Option D is correct because skin dimpling, nipple retraction, and a firm irregular breast mass are warning signs of possible malignancy that require immediate diagnostic imaging, such as mammography or ultrasound for urgent evaluation. Option A is incorrect because recommending warm compresses addresses comfort for benign conditions, like engorgement, but is inappropriate when clinical findings suggest possible breast malignancy requiring immediate diagnostic workup and urgent evaluation. Option B is incorrect because advising only monthly self-examination would delay further evaluation of findings that are highly suspicious for malignancy, and these findings require immediate diagnostic imaging rather than watchful observation. Option C is incorrect because scheduling a repeat examination in 6 months would create an unacceptable delay in evaluating findings that are highly concerning for breast cancer, where early detection and prompt diagnosis are critical. New skin dimpling, nipple retraction, and a firm irregular mass in the upper outer quadrant of the left breast. All new since the last annual exam. What should the nurse prioritise? Immediate referral for diagnostic imaging. This combination of findings is a textbook presentation of possible breast malignancy. Each sign on its own raises concern, but together they form a pattern that demands urgent evaluation. Skin dimpling means something underneath is pulling the skin inward, possibly a tumour attached to the Cooper ligaments or underlying tissue. Nipple retraction means something is pulling the nipple inward from behind. A firm, irregular mass is the opposite of what benign lumps typically feel like. Benign cysts tend to be smooth, round and mobile. The upper outer quadrant is also relevant because that's where the majority of breast cancers occur, since it contains the most breast tissue. The wrong options all involve unacceptable delays. Warm compresses are comfort measures for benign problems like engorgement or mastitis. Not appropriate when you are looking at possible cancer. Advising monthly self-exam only means the patient goes home and just monitors something that could be actively growing. Scheduling a repeat exam in 6 months creates a half-year gap, where a malignancy could spread from a treatable stage to something far worse. With findings this suspicious, you don't wait. You get imaging now, mammography, ultrasound, or both. Here's a WGU D443 OA exam tip for you. Skin dimpling plus nipple retraction plus firm irregular mass equals refer for imaging immediately. Never delay, never wait, never just observe. Quick recall hook. Dimple, retract, irregular. DRI means drive straight to imaging. Don't wait. 50. A nurse is counselling a female patient about menstrual cycle phases during a health education session. The patient asks what happens around day 14 of a typical cycle when the mature egg is released from the ovary into the fallopian tube. Which phase does this represent? A. The menstrual phase with uterine shedding. B. Ovulation when the egg is released mid-cycle. C. The luteal phase with progesterone dominance. D. The follicular phase with estrogen increase. What do you think is the answer? Correct answer, B. Ovulation when the egg is released mid-cycle. Explanation. Option B is correct because ovulation occurs around day 14 of a typical 28-day menstrual cycle when the mature egg is released from the ovary into the fallopian tube for possible fertilization. Option A is incorrect because the menstrual phase occurs during days 1 through 5 when the uterine lining is shed through bleeding, which is an entirely different event from egg release at the cycle midpoint. Option C is incorrect because the luteal phase occurs after ovulation, during days 15 through 28, when the corpus luteum produces progesterone to maintain the uterine lining, not during the egg release event itself. Option D is incorrect because the follicular phase occurs during the first 14 days when estrogen rises and the follicle matures inside the ovary, but this phase ends when ovulation occurs at the midpoint. The patient asks what happens around day 14 of a typical menstrual cycle when the mature egg is released. That's ovulation. The menstrual cycle in a standard 28-day cycle breaks into 4 distinct phases, and you need to know each one. The menstrual phase covers days 1 through 5. That's when the uterine lining sheds through bleeding. This is day 1 of the cycle. The follicular phase runs from about day 1 through day 14. During this time, follicle-stimulating hormone causes several follicles in the ovary to develop. One becomes dominant, and rising estrogen levels thicken the uterine lining in preparation. Then comes day 14, ovulation. A surge of luteinizing hormone triggers the dominant follicle to release its mature egg from the ovary into the fallopian tube. This is the most fertile point of the cycle. After ovulation, the luteal phase kicks in from roughly day 15 through day 28. The empty follicle becomes the corpus luteum and starts producing progesterone to maintain the thickened uterine lining. If the egg isn't fertilized, progesterone drops, the lining breaks down, and menstruation begins again. The question specifically asks about the egg being released at mid-cycle. That's ovulation and nothing else. The menstrual phase is bleeding, not egg release. The luteal phase comes after the egg is already out. The follicular phase builds up to ovulation, but ends when the egg releases. Here's a WGU D443 OA exam tip for you. Day 14 of a 28-day cycle equals ovulation equals egg release. If a question mentions mid-cycle and egg release, the answer is always ovulation. Quick recall hook. Day 14 equal sign egg is free. 14 and free. The egg leaves the ovary at the cycle's halfway mark.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.